Good morning, everyone. Nice to see all of you. We gave folks a little bit of extra time this morning. We obviously are in a different location than we have been at in the past, and I want to thank our colleagues here at the Department of Health and Human Services for being such gracious hosts. They've been an absolute pleasure to work with, and again, we appreciate them allowing us use of their space. I want to take a moment to welcome all of you, of course, and thank you for joining us for the New Hampshire Insurance Department 2025 annual hearing on healthcare premium and claim cost drivers. I want to take a moment to introduce a couple of members of our team. With the new location being so close to the department, I think we've got almost the entirety of the life and health unit here this morning, which is great. Helps to fill the seats. So first and foremost, of course, a face that is, I'm sure, very familiar to you now. Our Deputy Commissioner Keith Nyan is here. Michelle Heaton, who leads our Life and Health Division, is right over here. The Life and Health Market Conduct Unit is spread throughout the hall, so please welcome them, as well as our Life and Health Compliance team, led by Tori Fowler. She's right here, dead center. I also, of course, want to thank our Communications and Outreach team, Andrew Demers and AJ Kierstead, who always do a great job of getting the word out about our events, and they put together these snazzy presentations. Though this may have been Oliver Wyman, so I don't want to steal their good work. And I did want to take a moment to recognize somebody in particular, again, a very familiar face, a man who truly has been for the department the perfect example of a public servant. He has been a bit of a jack of all trades for us. He's been with us for a very long time. When Alex Feldable retired a few years ago and then failed at that retirement, I was quite thrilled. We needed help. We didn't realize just how much help we needed until Alex came in and did such amazing work as he had always done in the past. I like to joke that he technically was filling a part-time position, and Alex is just a horrible part-time employee. He doesn't know part-time. The man just goes full-time, hard, stays as long as is needed to get the job done. You're modest, I'm going to put it at hundreds of statutes in law in this state related to insurance and related topics that have Alex's imprint on them. And so I think Mrs. Feldable said enough's enough. And so he will be retiring next week. Maybe for good, we'll see. He may see back here next year, as it turns out. I don't know. But if it is in the event that it is his actual retirement, I want to take a moment to recognize and thank him. Alex, thank you sometimes. All right. On with the program. So each year, this hearing gives us the opportunity to look beyond the headlines and ask a simple but vital question. Is the health insurance market serving Granite Staters well? And as you'll see from today's presentation, the answer to that question this year is yes, and quite well. Our market is stable, competitive, and delivering strong value. While other states wrestle with big challenges, New Hampshire's blend of sound regulation and free market discipline continues to keep coverage both accessible and affordable. And I want to highlight just a couple of themes that you're going to hear throughout the presentation today. So today, over 95% of New Hampshire residents have health coverage, among the best rates in the country and the highest in New England. The individual market has grown over 50% since 2020, and our reinsurance program continues to attract younger, healthier enrollees. The next theme, premium stability and affordability. That is a central story of our presentation today. Across all markets, the average premium increase is just 0.1% in 2024, effectively flat. The individual market, the rates there declined by 2.3%, and our benchmark silver plan fell 3%. That helped New Hampshire achieve something that I find to be extraordinary. The lowest average individual market premium in the nation. Our small group premiums are about 10% below the New England average, providing that disciplined oversight works for both for both employers and employees. Consumer confidence in market competition. Consumers are choosing higher value plans. Gold level enrollment has risen from 18% to 24% in 2 years. Competition amongst carriers remains strong, all while maintaining a solid presence, those carriers are, which we're very proud of. And we're proud of the collaborative relationship that we have with all of them. And employers are staying in the market because it is affordable and predictable. Innovation and value. A major success story is our growth in value-based care. Contracts to reward quality and efficiency rather than just volume. Participation has doubled since 2022 from 18% to 38%. That's real progress towards bending the cost curve and aligning incentives around patient outcomes. Again, affordability and access. Families are feeling the difference. Deductibles declined across most markets, and out-of-pocket costs remain manageable for most, averaging just 8% of total medical expense for large group members. This is something I'm particularly proud of given my priorities as commissioner. Behavioral health claims rose 24% in the individual market, and primary care spending rose nearly 14%, a sign that more people are getting preventative and mental health care when they need it. Fiscal responsibility. There's a New Hampshire value. Financially, the market is sound. Roughly 85 cents of every premium dollar goes directly to medical care, and federal medical loss ratio rebates fell from $14.8 million to $1.5 million, meaning carriers are pricing accurately and consumers are getting good value. And so again, I like to brag on New Hampshire any opportunity that I get. So I want to reemphasize our national standing in a little bit of a closing perspective. It is really worth celebrating where New Hampshire stands nationally. Now, that is, of course, not to say that there's not more work to do. Just because we are in an advantageous position does not mean that the situation is affordable for every individual family and business in New Hampshire. But we've done good work, and that is worth recognizing and appropriately celebrating. So as you'll hear from Oliver Wyman, again, New Hampshire ranks first in the nation for the lowest average individual market premium, and that distinction reflects years of consistent stewardship, collaboration, and a shared commitment to balance, and not over heavy-handed regulation of the market, but rather steady governance. So what does all of that tell us? And you'll hear this, of course, in some detail. It tells us that New Hampshire's health insurance market is by and large working for consumers. Consumers are covered, premiums are stable, deductibles are easing, behavioral health access is improving, and the system as a whole is financially sound. And that really is a credit to everyone here in the room, because together, from insurers to providers to policymakers and the talented team at the department, we have helped to foster a market that reflects the best of New Hampshire values: practical, disciplined, consumer-focused, and resilient. So with that said, I would like to recognize the last guy that I didn't recognize, because he too is going to get a little bit of a special introduction. Dr. Jason Aziz and his team here in the room from our data analytics unit has done incredible work. It was a new unit within the department within the last year or two, Keith, I'd say. And Dr. Aziz has built a phenomenal team. They have put together some really phenomenal work, both for the legislature, internally to the department, all of it to help guide the work that we do at the department with real, reliable, in-depth data. And so for Dr. Aziz, this is like the Super Bowl, World Series, All-Star game wrapped up into one morning. He's worked incredibly hard. He's interfaced intensively with the team at Oliver Wyman. So I want to thank him and his team for their incredible hard work in putting this together. So Dr. Aziz, come on up. Yeah.
So thank you, Commissioner. And first, I'd like to thank all of you for coming here to our annual hearing. It's so nice to see your beautiful faces and smiles. And, we come from different areas and sometimes find ourselves, pursuing competing interests. But I'd like us to focus today on understanding what our common interests are. And if we can kind of pull those together and move forward, I see the potential for great reform to our healthcare system, which I think is in need of some of that. So I just wanted to take a second to echo the sentiments of Commissioner Bettencourt's comments about my friend and mentor, Alex Feldwebel. I hope I'm as bad at retirement as you are. So I learned a lot from Alex, and that's one lasting lesson I hope to take into the second part of my career and my life. But my life has been blessed to be part of his. So that's all I'm going to say because I made a promise to not talk too much about Alex. The other thing I wanted to say quickly, and then I'll end the greetings and salutations, is I see it as a privilege to have had the opportunity to do what the Commissioner was just talking about. He created this data division. And I think the opportunity for healthcare data now is never been more powerful. Big data and the access to data, and then changes in data governance have empowered the industry to have insights that can really inform effective policy, something else that the system is in great need of. So it's a privilege. Thank you for that opportunity. And I promise you and the citizens of the state, high level of responsibility and rigor with the way that we govern data, steward data, assess, analyze, and report on data. And it's really important to us. And the Commissioner gives us great autonomy to do just that. That said, we pride ourselves on the depth of the quality and quantity of the data we have access to. And there's a myriad of different sources of data. I am amazed every day at the breadth of that. I wanted to point out two key people in this room, sitting right here. Morgan Harris and Maureen Brooks, two of our data analysts that have dug deep in this endeavor to give you the best, most current, most recent, deepest, and most granular data analyses to help our colleagues at Oliver Wyman report on this. I can't wait to hear what you have to say. All that said, Oliver Wyman have been great colleagues. That sounds like a person's name. I'm not sure if there's actually a person named Oliver Wyman. None of that matters. People we know are named Dagny Grillis and Greg Bruce. They're going to tell you all about these great things that we're doing at the insurance department that, frankly, not a lot of people know, and it's a great opportunity for us. So without further ado, let's hear first from Dagny and see what she has to say about our markets, how they've shifted, and how great the work that we're doing at the insurance department is with regards to the premium levels in the state. Thank you.
Thank you. Good morning, everyone. Thank you so much for being here. I want to thank the Commissioner and then also thank everyone who's attending. Thank Jason and his team. It's been such a pleasure to get to work with everyone today. And we're really excited to share our results. So as Jason said, I'm Dagny Grillis, a healthcare actuary with Oliver Wyman Actuarial Consulting. My colleague Greg Bruce and I are going to take you through this presentation on the key findings from our 2025 preliminary report on New Hampshire's healthcare premium and claim cost drivers. We also have our colleague Peter Kaczmarek, who was instrumental in leading this product on our side, on the line with us to help with questions today. All right. So the goal of this report and presentation is to examine health insurance premium and claim costs and the factors contributing to these changes in these costs. This year's focus is on 2024, but we'll also be presenting on available information from early 2025. We do have a lot of information to cover this morning, so we'll be moving at a somewhat brisk pace, but there will be Q&A section at the end. I want to start with our key findings so you can be more aware of these items as I do go through this presentation. We'll also review these again at the end of the presentation. So some of the key findings here, the individual market did continue to experience substantial increases in enrollment into 2024 and further into 2025. We saw small group enrollment has continued to decline at a gradual pace, 11% over the last 5 years. The total medical expense, or be referring to it as TME, PMPM, that's per member per month trend in the fully insured market has increased substantially each of the last 2 years. And this is after a nearly flat trend from 2021 to 2022. This has been predominantly driven by increases in cost and mix. We've seen outpatient facility, professional, and pharmacy are the largest contributors to trend increases. Inpatient and outpatient facility and professional provider payment rate changes are lower in 2024 compared to 2023, but are projected to increase in 2025. And then finally, insurance risk margins were 3.7% less in the individual market, and then 2.8% and 3.4% increase in the fully insured small and large group markets, respectively. All right, at this time, I want to hand it over to Greg. He's going to take you through these first few sections in more detail. So here.
All right. Thank you, Dagny. And I echo Dagny's sentiment. Thank you, Commissioner. Thank you for the state of New Hampshire for having us here. These next couple of slides look at some comparisons between New Hampshire and the United States and compare it to the other New England states. The uninsured rate in New Hampshire, shown in navy, has continued to decrease from 5.1% in 2021 to 4.5% in 2024. The United States average uninsured rate, shown in dashed navy at the top, has steadily decreased from 2021, but increased this most recent year to 8.2% in 2024. This chart also shows the other New England states. When comparing New Hampshire to New England, New Hampshire's uninsured rate was approximately in the middle in 2024, with Massachusetts having the lowest uninsured rate at 2.8%, and Connecticut having the highest uninsured rate at 5.8%. This slide gives an overview and provides directional information on where New Hampshire residents are receiving their health insurance in 2024, based on information collected from the American Community Survey. As we reviewed on the previous slide, the uninsured rate in New Hampshire is around 4.5%, shown in this slide in the dark green at 4%. Of the approximately 1.4 million New Hampshire residents, this translates to approximately 62,000 residents not having health insurance. Approximately 62% of New Hampshire residents receive their health insurance through the private commercial market, either through their employer, shown in dark blue at 55%, or by purchasing their own insurance through the individual market, shown here in light gray at 7%. After this employer-sponsored coverage category, Medicare coverage is the next largest coverage category at 16%, shown in bright blue, followed by Medicaid in dark gray. These next slides compare the New Hampshire average premium to the average premium in the other New England states and the United States average. This first slide looks at the individual market using publicly available information from the CMS risk adjustment reports. Average premiums in the New Hampshire individual market, shown here in dark blue bars, exhibited a slight decrease in 2024. Across the United States, which is shown with the bright blue line, the change in average premium has had small increases year over year. When comparing New Hampshire to the average in New England, shown here in the yellow line, New Hampshire's individual market premiums have remained lower than the New England average, and that gap has widened over time. Note that the New England average in this slide only includes Connecticut, New Hampshire, and Rhode Island, because the other New England states have had merged individual and small group markets at some point during this analysis frame. And average premiums in this slide will vary by state due to plan design, morbidity, regional cost differences, and the presence of a reinsurance program, which New Hampshire does have. This slide provides similar information for the small group market using the same publicly available CMS risk adjustment report data. New Hampshire's small group market premium, again in the dark blue bars, continued to remain close to the United States average in 2024. Average premiums increased about 5.4% for New Hampshire and 6.1% for the United States from 2023 to 2024. The average premium in New England, again in yellow, increased 5.2% during this same time period. The New Hampshire premium continued to be lower than the New England average, and they were about 10% lower in 2024. And this slide is looking at the large group average single premiums in New Hampshire compared to the United States and New England. The CMS risk adjustment report do not apply to the large group market. So for this information, we are using the medical expenditure panel survey data, or the MEPS data. Similar to previous slides, United States average is in bright blue, the New England median in yellow, and New Hampshire in the dark blue bars. This shows that in the large group market, New Hampshire has been consistently higher than the US average until 2024, where it is now approximately equal. When compared to the median of all New England states, New Hampshire's relative position fluctuates over time, and in 2024, New Hampshire has the lowest average premium of all the New England states. This section will be talking about coverage shifts in the market. Here we're looking at health insurance enrollment by market segment and the overall shifts in these markets by category. This slide gives an overview of New Hampshire's Citus commercial insurance market industry from 2021 to 2024. And by commercial, we mean people who are purchasing insurance on their own or receive healthcare coverage through their employer. The gray bar in the middle shows the proportion of membership within each commercial market segment in 2024. And similar to prior years, the majority, or approximately 84% of commercial coverage, was purchased through employer-sponsored health insurance. The commercial market consists of the small group market, the large group fully insured market, and the large group self-insured market. And note that over half of the commercial market, or about 51.7%, are enrolled in these large self-insured groups. Due to a reporting difference in the 2024 data collection, the self-insured enrollment did see some opt-out carriers, so we are seeing a dip in the 2024 self-insured enrollment due to that reporting difference. It is crucial to note that the New Hampshire Insurance Department does not have jurisdiction over self-insured plans. It only has jurisdiction over the approximately 218,000 members enrolled in fully insured plans, which is indicated by the top three segments. On this chart, the right-hand side shows average enrollment by market segment for each of the past 4 calendar years. Looking at the top for the individual market, the number of individual members has increased every year from 2021 to 2024. We'll take a closer look at this individual segment in the coming slides. The small group market continued to experience slight decreases in membership each year, and the large group fully insured segment also experienced a decrease in enrollment. Overall, reported Citus commercial membership decreased from 2023 to 2024 and this current membership is about 452,200 members. Drilling into the individual market enrollment, this slide shows the share of membership by insurer. Anthem, or Matthew Thornton's market share, shown in dark blue, substantially increased from 2022 to 2024, where they increased from 50% to 73%. During this same time period, Ambetter, shown in bright green, it decreased for the first time in recent history, where it was 41% in 2022 and is now 22% in 2024. Harvard Pilgrim's market share in bright blue also decreased during this time period from 9% to 5%. The individual market customers, along with the small group market, tend to be very price sensitive. So as premium rates change and competitive positions among insurers change, this can lead to changes in market share. This slide drills into the small group market membership from 2022 to 2024 by insurer. In the small group market, enrollment declined from 2022 to 2024 by approximately 7,500 members. During this time, Anthem/Matthew Thornton gained market share from 2022 to 2024 from 55% to 71%, while Harvard Pilgrim and United lost market share. Enrollment in the large group fully insured market has decreased from 2022 to 2024 with a decline of 12,000 members overall. Anthem/Matthew Thornton, Cigna, and United each experienced a slight increase in market share over this time period. This slide shows a more long-term view of enrollment for the individual and small group markets. Through the annual hearing data collection process, membership is now collected as of April, July, and December of each year, and each dot on this chart represents a data point, and small group is shown in bright blue and individual in dark blue. Between April 2020 and July 2025, small group enrollment declined 11%, losing about 7,000 members. The individual market membership is more volatile, and what we see is that there are typically decreases in membership from early in the year to the end of the year, but this did not happen in 2021. The individual market experienced several changes in 2021. First, the New Hampshire State Reinsurance Program started on January 1st, 2021, helping to lower premiums in the individual market, which most likely also brought in enrollment. Second, the American Rescue Plan Act of 2021, or ARPA, expanded eligibility for premium subsidies and increases subsidies to those who are already qualified. These subsidies were extended into 23, 24, and 25 through the Inflation Reduction Act. And lastly, there has been extended special enrollment periods. All of these factors likely contributed to the enrollment increases we have seen starting in 2021. This slide goes one step further and drills specifically into the individual market enrollment and breaks it into 4 different categories. The non-exchange members in dark blue. This includes enrollees in ACA plans off exchange and also includes grandfather or grandmother transitional enrollees prior to 2023. The bright blue line, which is on exchange enrollees who are not receiving any subsidies. The light gray line are exchange enrollees above 250% of the federal poverty level who receive advanced premium tax credits or APTCs. And the yellow line are exchange enrollees between 138% and 250% of FPL who are eligible for both the APTCs and the cost sharing reduction subsidies. The subsidized population in gray and yellow in these on these lines increased from April 23 to July 25 by 18%, or approximately 6,100 enrollees. The non-subsidized population in blue increased substantially during this time frame, about 30%, most likely due to the growing popularity of ICRAs. Consistent with individual and small group markets shown on the previous slides, this slide shows small or large group fully insured in bright blue and the self-insured in dark blue membership from April 2020 to July 2025. The large group fully insured segment has experienced gradual decreases until a slight increase in the most recent year, losing about 6,000 enrollees over this time frame. Please note that, as mentioned previously, due to enrollment changes for the self-insured plans, you cannot compare the most recent 2024 data to prior years. These two tables compare New Hampshire commercial situs enrollment on the top with Medicaid and individual market enrollment shown on the bottom. Total commercial enrollment is a combination of the 4 segments we previously looked at: the individual, small group, large group fully insured, and large group self-insured. And the individual market enrollment, shown in the dashed dark blue line, is a subset of the commercial situs shown above. We separated out the Medicaid enrollment into standard Medicaid and Medicaid expansion, also known as the Granite Advantage program. From April 24 to July 25, the reported commercial enrollment in New Hampshire decreased. Medicaid enrollment has remained stable since December of 23, and from December 21 to December 23, overall commercial enrollment increased by 1,000 members. This slide takes the New Hampshire individual market exchange membership and examines their metal level in 2023, 2024, and 2025. The metal level represents a plan's actuarial value or benefit richness. Generally, bronze plans have lower premiums but higher cost sharing, while silver and gold plans have higher premiums and lower cost sharing. For members on the individual market exchange, there was a shift away from the silver plans to mostly bronze and the richer gold plans. From 23 to 25, the percentage of enrollees in gold plans increased by 6 percentage points. This is most likely due to enhanced subsidies under ARPA and the Inflation Reduction Act, along with the continued benefit of the New Hampshire reinsurance program. The premium reductions from the reinsurance program and the additional tax credits allow some enrollees to afford these richer gold plans. In the non-exchange segment, we also see a shift away from bronze and silver toward gold plans. The percentage of enrollees with bronze plans and silver plans decreased, while the percentage of enrollees with gold plans increased, for a total approximate 12% shift over this time. These shifts can be viewed as positive in that enrollees in this segment can afford these richer plans. This slide covers the same data as the previous slide, but for the small group market. From 2023 to 2025, membership in the small group market by metal remained fairly consistent. Another item of note is that in 2025, 6% of the small group enrollment is in bronze plans. This is in contrast to the individual market segments, where approximately 37% of individual exchange members are in bronze and 16% of the non-exchange are in bronze. Okay, in this section, we're going to be talking about premium levels and cost sharing. This slide gives a picture of what happened to premiums in New Hampshire over the most recent 4 years. These premiums include both the employer and employee portion of the group market premiums, and they are prior to subsidies in the individual market. The average fully insured premium, PMPM, in New Hampshire increased only 0.1% from 2023 to 2024, remaining mostly constant. The individual market decreased 2.3% from 23 to 24, while the small and large group market premiums increased at a slightly higher rate of 4.6% and 2.2% respectively. Average premium levels in the individual market continue to be lower than the group market in 2024. Based on the 2024 Employer Benefits Survey from the Kaiser Family Foundation and the Health Research and Education Trust, in 2024, average premiums in the employer market across the country increased 7% for single coverage and family coverage. So compared to those figures, the New Hampshire small group and large group premium increases are lower than those on the national level. This chart looks at the change in the second lowest cost silver plan in the individual market from 21 to 25. Rates and rate changes for the second lowest cost silver are commonly reported because this plan represents the benchmark plan from which federal premium subsidies, or the APTCs, are calculated. Keep in mind this only represents one plan as a data point, and the insurer offering the second lowest cost silver plan can change from year to year. The change in the individual market's second lowest cost silver plan, or the benchmark plan, was negative in 2025 at negative 3%, following 2 years of increases. Across the United States, the average change in the second lowest cost silver was 4.2% in 2025, so New Hampshire is lower again than the US average. The premiums in the previous slides were all before the APTC subsidies were accounted for. This slide is an illustrative example of what a 40-year-old non-tobacco single policyholder in New Hampshire would pay for the second lowest cost over plan and the median bronze plan in 2025 under various income levels. As explained previously, ARPA and then later the Inflation Reduction Act increased the financial assistance to those who are already qualified for subsidies. Those are members below or at 400% of federal poverty level, and the expanded eligibility for premium subsidies for those above 400%. $325 PMPM is the full premium PMPM amount for the second lowest cost over plan in 2025 for a 40-year-old member. $301 PMPM is the full premium for the median bronze plan in 2025 for a 40-year-old member. And at the far left, we show members with an FPL between 133% and 250% who will pay between $0 and $61 per month for the median bronze plan and between $0 and $85 per month for the second lowest cost silver plan. These enrollees will also receive cost sharing reduction subsidies, which will increase the benefit richness of their plans to either 94% actuarial value, 87% actuarial value, or 73% actuarial value, depending on the income level. This slide is looking at the average cost sharing in the New Hampshire commercial market. The bars represent cost sharing per member per month dollar amounts, and the numbers across the top, the percentages across the top, represent cost sharing as a percentage of total medical expense. Member cost sharing includes cost incurred by members in the form of deductibles, co-payments, and co-insurance. Small group members incurred the highest amount in member cost sharing on a PMPM basis at $137, which translates to approximately 21.2% of total medical expense in 2024. The large group self-insured members incurred the lowest amount at $59 PMPM, or 8.2% of total medical expense. In contrast to the individual non-CSR segment, which incurred $133 PMPM in 2024, individual market enrollees with cost-sharing reduction subsidies incurred $77 PMPM in 2024, which is 11.7% of allowed claims costs. And now I'll pass it to Dagny to cover claim trends and utilization.
Thank you. All right, so yes, let's get into our claim trends and utilization. So everything that Greg has been taking us through that we've been looking at up to this point was related to premiums or member cost sharing. So those are the costs that fully insured employers or consumers incur directly. Now we're turning to claims and utilization, which is the actual experience that ultimately feeds into that premium development for this fully insured segment. The individual market total medical expense per member per month is shown here, and you see levels increased 11.9% from 2023 to 2024. The annualized trend from 2022 to 2024 in the individual market was 7.2%. Similar to the individual market, the group markets allowed claims PMPM levels increased substantially from 2023 and 2024 at 9.1%. The annualized trend from 22 to 2024 in the fully insured group markets was 9.8% total. The next several slides we'll look at will explore further what has happened in 2024 compared to prior years. So in this chart, it takes the combined fee-for-service small group and large group fully insured trends from previous slide and breaks it into two components, your utilization and then the unit cost and mix. So utilization is the number of services that were provided. Unit cost and mix trends are a combination of the change in the unit price of specific services or changes in the mix of providers being used by patients. In 2022, we saw a fairly low overall trend at 1.7%, driven by negative 6.6% utilization trend and then that combined with an 8.9% increase in unit cost and mix trend. In 2023, the utilization trends were higher compared to 2022, with the utilization trend at 1.6%, but the cost and mix trend that year slightly decreasing to 7.6%. And then finally, in 2024, utilization trends increased slightly to 2.7%, while unit cost trend continued to decrease to 4.7%. In addition to higher payment rates to providers, insurers cited more expensive outpatient procedures, like the more expensive surgeries, were driving up these mixed trends. The numbers across the top are average the trends from 2023 and 2024. They're in the top bold. So on a combined PMPM or per member per month basis, the average annualized trend from 2023 and 2024 is 8.4%. Next, as part of the annual hearing data collection process, insurers provided average unit price changes or payment rate changes at the major service category level for the current year and then the projected year. This chart is an aggregation of that data for inpatient and outpatient facility combined, so that's the dark blue that you see, and then for professional services, which is the light blue through 2024, and then in 2025, the projections, you see professionals, that light blue in the prior years has been split into professional physician and then professional other, and so that's the yellow and the light gray respectively. The combined inpatient and outpatient facility provider payment rate changes and professional rate changes were slightly lower in 2024 compared to 2023 and are projected to be slightly higher for professional in 2025. Also note, as I said, that we have split this out in our projection year. This slide shows the total PMPM trends by service category for fee-for-service claims for our group markets, similar to what we saw on a couple of slides ago where utilization trends have fluctuated greatly. PMPM trends or per member per month trends have fluctuated greatly over the past couple of years for each of the medical categories. So inpatient, outpatient, professional, and then also pharmacy and other. Professional, other, and then pharmacy service categories have the highest trends in 2024. Next, we want to look at this slide shows the average annualized fee-for-service trend from 2022 to 2024 and shows which service categories are the largest drivers of that trend. How large of a driver the service category is depends on both the size of the service category and then the overall trend of that category. This shows the outpatient facility is the largest driver, contributing 37% to the overall trend during this time period, followed by professional services and then pharmacy. While the percentages of the components that contribute to trend can vary, outpatient facility is consistently the top driver of claims growth. Taking a closer look at pharmacy trends, the bars on the left-hand side represent pharmacy costs covered under the pharmacy benefit or traditional pharmacy spend. The percentages in parentheses next to the pharmacy category labels show the percentage of the traditional pharmacy spend that each category represents. The pharmacy trend in the group markets in 2024 was 14.2%. This comes after a 2023 trend of 4.3%. Now looking at specialty drugs, so specialty drugs are the generally high-cost medications that treat complex and chronic health conditions and may require special handling. Specialty drugs can include things like chemotherapy and immunotherapy drugs, along with drugs to treat HIV, multiple sclerosis, inflammatory conditions, hepatitis C, and cystic fibrosis. They can show up either under the traditional pharmacy benefit in the specialty category or sometimes under the medical benefit, which we're showing on the far right side of the chart here. If they show up on the right side under the medical benefit, it generally means they're being administered in a physician's office or in a hospital setting. All insurers generally saw substantially higher specialty drug trends in 2024 compared to the prior year, driven by specialty drug, but also by brand non-specialty, which includes things like GLP-1, which we'll discuss on the next slide. Specialty drugs continue to comprise the largest portion of traditional pharmacy spend at 55% in 2024, by 5.7%, and they represent a sizable portion of PMPM spend at $49 PMPM, or per member per month. The combined specialty pharmacy and pharmacy under the medical benefit represented 67% of total traditional pharmacy and pharmacy under the medical benefit spend in 2024. Something new that is included this year we're excited about is we requested data on the GLP-1 and GIP, so the glucagon-like peptide one, and then GIP is the gastric inhibitory polypeptide drugs. Within the brand non-specialty pharmacy category, we show the rapid expansion of allowed costs for GLP-1 and GIP drugs. The average annual growth since 2020 is 41.8%, and the average PMPM in 2024 is estimated at approximately $13 per member per month in the fully insured group markets. The individual and group markets follow similar trends from 2020 through 2024. Throughout this report, the pharmacy information is presented net of prescription drug rebates. So rebates are those amounts which are paid to insurers or to the pharmacy benefit managers, the PBMs, from drug manufacturers, reducing total pharmacy cost. Prescription drug rebates increased from 2021 to 2024 and represented 30% of the gross pharmacy allowed PMPM. In 2024, pharmacy trend gross of rebates was 13.9% compared to 14.2% net of rebates. The total pharmacy rebate dollars across all commercially fully insured markets, excluding UHCFP, was $87.7 million in 2022, $118.8 million in 2023, and then $135 million in 2024. Also new to this year's reporting is this slide showing the amount for behavioral health and substance abuse in the group market. Majority of the spend for behavioral health and substance abuse is for professional other and then for pharmacy services. The total spending on a per member per month basis increased by 7.4% from 2023 to 2024. Now, taking a closer look at pharmacy trends in the individual market, the pharmacy trend in 2024 was 10.7%. This comes after a 2023 trend of 11.6%. Looking at specialty drugs, similar to group market specialty drugs, they increased at 13.8% from 23 and 24 and continue to comprise the largest portion of traditional pharmacy spend at 54% in 2024, followed by brand non-specialty, which made up 26%, and then generic, which make up the 20%. The pharmacy under the medical benefit trend for the individual market was 11.4% in 2024, bringing the per member per month spend to $52, which is slightly higher than the $51 PMPM of the group markets. Similar to the group markets, we also have looked at the GLP-1 and GIP allowed claims per member per month, and we see these have continued to increase annually in the individual market as well. The average allowed per member per month for GLP-1 and GIPs has steadily increased annually from $2.60 in 2020 all the way to $11.28 in 2024, so a 44.3% annual increase on average. Looking at the individual market at behavioral health and substance abuse, allowed claims per member per month increased in almost all service categories and by 24.4% in total from 23 to 24. The behavioral health and substance abuse share of total allowed claims was 9.6% in 2024 compared to 8.6% in 2023. This bar graph compares the distribution of member months for the individual, small group, and large group fully insured markets by their annual allowed claim cost. For example, in the individual market, there's a bar on the left here, 13% of members had no claims in 2024, so that's the dark blue at the bottom. 32% or 32.5% had between $1 and $999 in green in annual allowed claim spend, and then so forth as you move up. The distribution by market segment is somewhat similar, except at the highest spend levels where the individual market had 20.6% of claimants with $5,000 or more in annual claims, while the small and large group market segments had 24 and 27.4% respectively. Note that while members with over $5,000 in spend comprise only 20% to 27% of total membership, so those combined gray bars at the top, they represent between 84% to 87.5% of total allowed claims for each of the market segments. Compared to the prior year, there were more enrollees with claims over $5,000 for each of the market segments. For example, in the large group segment, so on the far right, last year there were about 25% of members with over $5,000, and now there's 27%. So we also asked insurers to report on primary care per member per month spending by market segment for 22 through 2024. Similar to last year, the definition of primary care was provided by the New Hampshire Insurance Department to ensure consistency in reporting among the insurers. Primary care allowed claims per member per month represents 6.2% of total fully insured allowed claims in 2024. There was an increase in primary care per member per month from 2023 to 2024 in all market segments. I'm sorry, I realized I did not advance. Apologies for that. So this primary care. So the overall fully insured market trend from 23 to 24 was 13.8%. And the primary care PMPM for the individual market of $38 was similar to the small group, $41, and then large group at $42. Please. The last two slides in this section present some utilization data by market segment for two key utilization metrics, so inpatient admissions and emergency department usage. Inpatient admissions, shown on this chart here, decreased in each of the fully insured markets from 21 to 2022, with the largest decrease in the individual market. From 2022 to 2023, inpatient admissions increased in all segments, with the largest increases also in the individual market. Insurers stated that the 2022 to 2023 trend in the individual market is driven by an increase in deliveries and newborn admissions, along with musculoskeletal and nervous system admissions. Inpatient admissions increased in each of the fully insured market segments from 2023 to 2024, except large group. The 2024 inpatient admit levels are still below the levels in 2021 for each market segment, except individual where it is higher. Similarly, we looked at emergency department usage. This is a key metric. There's been a fairly steady increase since 2021 through 2024. The individual market experienced the largest increase from 2023 to 2024 at 15.7%, while the group markets were lower at 7.9 and 6.2% increases. The overall increase across the entire fully insured segment was 10.6%. The individual market had the highest number of emergency department visits across these three segments. More than one insurer cited that an increase in preventable emergency department visits for things such as digestive and abdomen issues is one of the drivers. So this section we want to look at now is on medical loss ratios, expenses, and then risk margins. So this slide shows risk adjustment payments by insurer for the past 4 years in the individual market. In general, insurers who have healthier members will pay money, so shown in the red, and insurers who have sicker members will receive money in risk adjustment, shown in black or white or above that horizontal line. In the individual market, Matthew Thornton Health Plan, Anthem, was assessed for a $16.4 million payment for 2024 risk adjustment. On the other side, Ambetter and Harvard Pilgrim had receivables that were smaller in 2024 compared to 2023. As discussed previously, there's been a large increase in enrollment in the past couple of years, and there's been a lot of shifts in market share among insurers, which leads to volatility of these risk adjustment results. Looking at the small group market and risk adjustment, the total amount distributed from the risk adjustment program was $7.5 million in 2024, which is slightly increasing over the previous time period. The other observation is that the total amount of money redistributed in the small group market is lower than what we saw in the individual market. Some of this is just due to the smaller size of the small group market, but it also speaks the more even distribution across small group insurers compared to individual insurers. So next we look at this graph, which we show a distribution of the premium for benefits, so the dark blue, the admin expenses in the gray, taxes and fees in the light blue, and then the margin in yellow at the bottom for 2024 in the individual market. This information is based on data from the Federal Medical Loss Ratio, or MLR, reports, but is not meant to replicate the federal MLR calculation, as the federal MLR rebate formula has some additional adjustments and is based on a 3-year average of results. The risk margin in 2024 was negative at 3.7% after MLR rebate, and changed from positive margin reported in 2023 at 2%. The annual volatility speaks in part to the substantial changes that have taken place in this segment over the past several years, including the population changes and then the higher trends than priced by the carriers. Then finally, we have a premium distribution information for 2024 in the small group, so that's on the left side, and then large group on the right. The risk margin in the group markets has been more stable than the individual markets, ranging from roughly 2 to 6% over the past several years. So to kind of wrap up here, we want to go back to our key findings. So I won't read these all to you again. We've come to our last slide, which are the same as before. But I'll leave them up here for reviewing. The full preliminary annual hearing report is available on the New Hampshire Insurance Department website, which provides more context and additional information beyond what we were presenting here today. I would like to, again, greatly thank the New Hampshire Insurance Department staff and all of the insurers and their efforts in providing data and information used in this presentation and report. And then we have time for questions.
So, AJ, do we have any questions online? Let's start with the audience. If there are any questions germane to the presentation here, we do have another special presentation topic I know you're aware of, and you heard a lot from this presentation about GLP-1s. And I'm getting signals from colleagues, friends, and family that that's a broken record. But that's not my broken record. I can remember when I endeavored as a young professional, the first career choice that I had, that was somewhere in the mid-1980s. Overweightedness and obesity was an issue then. And I swore I would resolve that issue. And here I am. You know, I know what you're saying or thinking, right? Like, he doesn't look dental, right? Maybe that's not what you're thinking. But you're thinking that, yeah, you're right. Obesity's been here a long time. It is indeed an expensive condition for us to deal with in our healthcare system. So we're going to hear lots more about that. I'm really excited to hear all that. And I promise you, zero censorship from me. But with regards to anything presented in this presentation, does anybody here have any questions? Yeah, that's a signal that you did a really great job. Yeah, I did see Ben Bradley from the New Hampshire Hospital Association.
Right, thank you.
Yeah, hi Ben.
I just had a quick question on the statistics you provided relative to the growth in outpatient services, and whether that's a good sign rather than having those services provided at an inpatient facility. For example, I know some of our members are trying to provide services at an outpatient facility versus an inpatient to help with the challenges around patient throughput and patients in an appropriate setting, low cost. So I'm just wondering if you have any reflection on what that growth in outpatient service through ambulance, whether it's an intentional effort appears to be an intentional effort to meet those services to a lower cost site.
So I think we could follow up to see if there was a specific insurance or insurer sightings of like what the drivers were. I think though, as you mentioned, like it is an overall trend we're seeing, especially with value-based care being sort of predominant now, of trying to move those more costly services from inpatient to outpatient and really be conscious of those sites of services and who's performing it. So yeah, I think it is an overall trend we're just seeing in the medical industry in general, but we can follow up on that.
Yeah, and our viewpoint and at the insurance department, and just as a health economist, efficiencies, gains in efficiencies are a key, in my lens, optimistic target for us. What are some things we can do? What are some things we can't do? We can become more efficient at delivering healthcare. So I think that harkens to your question, and the signals implicit in that are there more efficient ways to take care of the health of these human souls that the system is designed or intended to care for? And, I think of it as this, healthcare gap. We have the health of the system, but not to be lost on the health of the souls the system was designed to care for. And improvements in efficiency can narrow that gap. Maybe, never eliminating it. That's probably a supposition that may never exist. But when you say that this increase in expansion of outpatient healthcare delivery, we ought not look at that in and of itself as nefarious. Maybe that's a reflection on us getting better delivering healthcare in a more cost-effective manner. I hope that's true. In all of my altruisms and optimisms, I think that is true, because that's how societies evolve and markets evolve. They usually get better. Cars are better, homes are better, medications are better. Healthcare delivery vehicles should, by and large, if we do our job and ignore our uncommon interests and focus on our common interests, the system should make it better and more efficient. And I think that's what I see with regards to the question that you asked. Let's make that be true, become true. For sure, I think it can. Yeah. Does that make sense? Any other questions? Wow, that was fantastic. I know so much more because of it, despite the fact that we've been working on this daily for months. And so, Ron, you're from Texas. Florida. You're not Texas. And from
Pittsburgh.
Thank you for coming to the Grand State in New England.
Yeah, thank you for having.
Around these parts, we call people like this wicked smart. And indeed you are. And thank you for informing our audience and our citizens, policymakers, and industry stakeholders on something so important and near and dear to our hearts and our work. So thank you very much. All right. So, and the way I look at it, I always have since a young person, in 1985 and 2025, that's like 40 years. Knowledge is power. Who believes that? Knowledge is power. I love that word power, right? That's implicit in my persona is strength over time, or force times velocity time. And people who know me the best know that I'm like the most impatient person in the world. So I can appreciate things happening quickly, but I know the reality, and Alex has taught me a lot about this, is that these types of things take time. So I promise a modicum of patience in my future. But knowledge is power, and the power of this information sharing today only is potentiated or becomes real or becomes of real value if you empower it. If you do things that exercise these new insights in policy, whether it's legislative policy or institutional policy or personal policy, a key emphasis of our unit now in Morgan and Maureen's work that may be counterintuitive to you in this state government setting is consumer responsiveness. To what extent are consumers responsible for the optimal function of healthcare in their responsibility, moral responsibility, and economic responsibility? How culpable are we in this whole paradigm? And, you may presuppose that I have a viewpoint on that. What's yours? And how do we as individuals who are not only participants in the market, but also healthcare consumers ourselves and leaders of households that set the stage for how healthcare consumption trends evolve in the household and how we look at that. That's not a trivial matter in what brings us here today. And I think I'm remiss to not point that out to you. All great people with great interests, even though they differ slightly. Okay, so I did want to, I would be also remiss to not pay a little extra attention or emphasis and respond to questions we've already received at the insurance department that relate to what you see in the news a lot today, yesterday, and the last probably 3 months. This attention to the premium tax credits and the potential for their repeal. And there were a few slides there that reflected that. And but I'm not the person to talk much about that, because much of it exceeds the limits of my knowledge. And I did want someone else to talk about that, who was also wicked smart and not from New England and is here in this room today. So I'm hoping, Morgan, you can open up the slides that reflect that, because we're getting questions already about what's going to happen to the individual market membership and the premium if this were to if the advanced premium tax credits were to stay repealed or were not to. So I'd like to invite Attorney Michelle Heaton, our Life and Health Director, up here, who knows much more about it than I do, just to share some insights that the department has on that. And then after that, there'll be some absorption phase, I hope, because it is a complex topic and it is counterfactual. We're trying to predict what has yet to exist. And Michelle has her finger on the pulse of that, and I'd love you to hear that and absorb that and contextualize it into all the different types of work that you do. After that, we'll take a short recess and then come back, and please do come back. I really hope you do, because it's such an important topic, and we really have world-leading experts in this topic. Yes, world, not just New England, not just New Hampshire, in the world, who have done the most innovative work on this, and I'd love you to hear what they have to say. So without further ado, this is Michelle Heaton. You already know her.
So as you all know, if you've been to our annual hearing before, most of the annual hearing is retrospective data. We're looking at plan year 2024, but the APTCs and what's going to happen in the next week when open enrollment starts is kind of the elephant in the room. So even though we don't normally talk about these things, we did want to just briefly touch on them to maybe help ease everyone a little bit. So this is just a quick slide we put together. This is our average benchmark premium. So that's the second lowest cost silver plan for the 40-year-old non-smoker. So there's a lot of policy decisions that have been made in New Hampshire that I think help position us to still have relatively low premiums compared to the rest of the country. And one of those big ones was our 1332 waiver. So that's our reinsurance program that was implemented in 2021. So if you see up here, this is where back in 2018, that benchmark premium was. It was pretty high. When we implemented our reinsurance program, which is the purple line right here, you'll see that there's this big drop in premium. Obviously, COVID hit in 2020. That probably shifted some priorities for people. It also led to increases in enrollment in our market. But the actual drop in the cost of premium, when we're looking at the premium rates for 2021, that's what was effective January 2021. The carriers were already setting their rates earlier in their year. So that gets lost on a lot of people, is when we're talking about setting rates for the next plan year, when we're setting rates for plan year 2026, that work started at the start of 2025. And, our carriers and regulars work very closely with our carriers to try to get to the best possible rates we can based on what's happening. So that big drop for when the reinsurance came about is mostly attributable to the reinsurance program. You'll see the ARPA subsidies came in effect on the yellow line a little bit later into 2021. That was well after open enrollment and after rates were set for that year. So while it led to an increase in enrollment, it is not attributable to where our benchmark or plan was for 2021. But because we had more people coming into our market's growing, we did see some more increases or decreases in our benchmark plan, and it's remained relatively low. Now, you'll see that for 2026, it's going up. It's still not going up anywhere near where we were in 2018. And part of that is because of the policy decisions we've been making in New Hampshire. We have our reinsurance program. We have, been moderate in our reforms in the insurance market. So a lot of those decisions that are made by our legislatures, by the department, by our carriers, all of that contributes to still keeping us relatively low. And you'll see the blue line, we do not have data for across the country what rates are going to do, but they're going to go up like they are in New Hampshire. We know that much. We just don't know the exact amount. So that's why that line kind of ends at 2026. And then I want to go back to this slide because this is also a really important slide when we're talking about the advanced premium tax credits. The tax credits themselves are not expiring. It's the enhanced tax credits. So even if those were to expire at the end of the year, there are still people who are still going to qualify. It's just going to be a smaller portion of people who will get the benefit of those tax credits. When you look at the dark blue and the light blue line, I believe, those are the ones that are not receiving any subsidies. That's still about 48% of our market. So those people, whether the APTCs are extended or not, are not directly benefiting from them. So those people will likely remain in the market. The gray line where we see the big increases after ARPA and the Inflation Reduction Act, those are the people who are most likely going to be impacted by the whether those enhanced APTCs get extended or not. Because they're the people that right now may be receiving a subsidy, but if those enhancements go away, may not be receiving it or are going to be receiving less. So that's the portion of the population that's probably the most sensitive to what's going to happen in the next week. And then the yellow line, those ones are already receiving substantial subsidies. They will still be receiving substantial subsidies, but depending on a number of factors, that could change a little bit as well. So overall, we have a good mix in our market of people who would be qualifying and who would not. So just even if these enhancements do go away, it's not going to cause a drastic drop off in enrollment in our market. One of the things that's not evident when we're talking about the enhanced premium tax credits, that's the amount that consumers get to help bring down their monthly payment. It does also impact the overall cost of premium in the market because it helps bring in more people, more healthy people, because healthcare is more affordable with those enhancements. But overall, we estimate that the impact of those enhanced subsidies on rates is only about 3 to 5% roughly. So even though we are going to be seeing some big increases in premium, not all of that is attributable to the advanced premium tax credit. A lot of it is those same types of trends we were just going over that are going to be continuing through 2025. And that's the information that the carriers are looking at as they're setting their rates. So I just wanted to level set that a little bit. I know normally we don't get into the future, but it seemed hard to avoid this year. So with that, I think we're going to break for a little bit. And when we come back, we'll be talking about GLP-1. Okay.
So again, thanks for coming back to discuss what I think is going to be a fascinating topic and one that is a key driver of health insurance premium increases, weight loss medications, and specifically, of course, GLP-1 drugs. Despite decades of awareness and interventions that have had mixed results at best, the prevalence of overweightness and obesity continues to increase. I think you've got the slide here that can bear out exactly what I'm talking about there. So without question, this pervasive condition represents one of our culture's most pressing public health issues, and a costly one indeed. In 2019, approximately $180 billion a year was spent in the United States attributable to obesity. And at the individual level, healthcare costs were approximately $1,800, Dr. Aziz, higher for obese individuals than non-obese individuals. So, given those numbers, given the prevalence of this topic, on the front of mind for people today. We have convened a diverse panel of world-leading experts to discuss this contemporary issue from various lenses, that of a clinician treating the negative effects of obesity on human individuals, to that of a health policy economist working on balancing the benefits of mitigating obesity at the individual level with the cost to the overall healthcare system and society, to a pioneering individual in energy metabolism who may share novel insights into our culture and that may hold the key for sustainable results in our population. So, those individuals, and those were quite descriptions. They'll be fighting over who gets to be who. Sarah Finn is here joining us. She is from Dartmouth Medical Center, their unit or section on obesity. Sarah Eamon from ICER, which is the Institute for Clinical Economic Review, are both here to talk about this. And Dr. Az, I think you're part of this too.
Yeah, I'd like to just say a little more.
Sure.
So, no. Thank you for,
Jason makes me look brief.
yeah, no, that was thoughtful. It was something remarkable in that message. $1,861 on average.
That's a dime.
Higher annual healthcare expenditures for somebody if they are obese compared to their non-obese counterparts. So that's like almost obviously $2,000. But if you think about the prevalence of obesity and, multiply that times $2,000 times, and factor that into a population of 350 million American souls, think about the massive cost burden to the system. It's probably the most pervasive individual disease. I think Sarah's going to talk about it that way, which I think is the right way. But that's what we do at the insurance department. We manage the very important resource of the health insurance industry, which just so happens that's the way we finance healthcare delivery in our society. Sarah's going to talk about that balance and act. So it was important to us to comprise a set of, world-class leading experts on this really emerging and innovative and novel topic that doesn't seem so novel to me somehow, some way. So our audience gets a balanced perspective because it's quite a complex one. And I think that's for sure a message you're going to leave here with. I wanted to point out some of the other work that the department is doing with prescription drug cost and utilization, because, I hear the anecdotes out there in social settings about farmers doing this and farmers doing that, as though there's some widespread conspiracy to make us worse off. You heard my commentary about we become better off with innovations, and I can't think of a system that's more true than the healthcare system. Innovation makes us so much better off. We have to acknowledge that. With that said, we track closely prescription drug cost and utilization on a set of interactive dashboards. We hope that our audience, the industry, policymakers, citizens, others, are aware of this and make use of this to find out what drugs are driving healthcare costs, what drugs have the highest cost per prescription, the highest utilization, the highest year-over-year cost increases. We've tried to empower the viewer by filtering on several key domains, including years of interest, therapeutic classes, and reporting domains like frequency versus cost, or cost, the relative cost per prescription, 30-day equivalents. Please let us know if there's other ways to express this important information that may be more useful or more insightful to you or anybody that you know. An example of a very useful way to express this is to filter by drug therapeutic class. So you can see, wow, providers, there's a lot of therapeutic options within one class of drugs, and there's massive price variation. Tongue-in-cheek, you may also notice that they have these awkward names that makes you wonder, discussion last night, makes you wonder, where did these names come from? Aside from that tongue-in-cheek comment, there's a lot of useful information here. This is on our New Hampshire Health Cost website. There it is. I'm blessed to have the opportunity to have made you aware of it. Remember that empowerment thing? Let's empower this to help, share with provider populations and individuals that there's competition. Competition is supposed to drive prices down. It's that reality is rather lagging with the brand exclusivity forces in prescription drug markets. A way to overcome that is with knowledge and power, and reaching out to your provider or your insurer to say, hey, there's this drug and it's expensive for me, but what about the therapeutic equivalent or the biosimilar? So that's really important to us. My other slides real quick, and some of it is redundant, so I'll not expose you to the dumb English of redundancy on this, but I did have two key epitaphs in this message. And so we did a webinar a couple weeks ago. I'd appreciate if you made yourself aware of some of the viewpoints that I shared there. And they're not prevailing over anybody else's viewpoints. They just happen to be my viewpoints. Remember that 1985 thing. So I've been around it a long time. My biggest liability as I stand here at this podium is that I've really been an athlete my whole life. And, my sister pointed out a long time ago and continues to that, Jason, you don't know what it's like to be obese because you've never been obese. And I'll end the debate there, but she's not wrong about that. So I understand the limitation of my viewpoint with regards to how do we deal with this pervasive issue at the population level. That's why we have people who are much better off than me at helping you with that. Next slide real quick. So I think, Morgan, can you? Yeah. So these are just messages, right? Excess costs, $180 million. I think it's more than that. That's 2019 US dollars. I think it's closer to $200 billion a year. Those are spurious measures. They're population attributable fraction measures, but I like the measure of the $1,800 times 0.4, 40% of the population is obese, times 350 million people. In other words, that's a lot of money. We don't have to do the math right here, right now. I did want to point this out on this slide. Definitions. The eligible population to receive these therapies, right, is fully dependent upon how we define obesity. As a note, the self-proclaimed athlete my whole life, I'm BMI obese. Okay. So BMI obesity is classified as a BMI of 30 kilograms per meter squared or more. And there's different classes of obesity. And the World Health Organization and the CDC have slightly variant or deviant definitions for that. Next slide. But I just wanted you to be aware of that. And now with this whole focus on clinical obesity treatment, therapy, prevention, there's an expansion in the number of approaches to classify obesity. In epidemiology, we call the errors in that are noted as misclassification bias or misclassification of exposure. Obesity causes disease, right? So obesity in this case is an exposure. But if we misclassify obesity, it's really bad on how we understand the role of obesity on disease. And because of that, there's lots of scientific and clinical interest in having a better definition, better than BMI obesity, right, sir? So she'll tell you more about that. I just want to point your attention to the bottom of the slide, which is the crude, unadjusted prevalence of obesity. According to the NHID, my Bible, and it's about 40.3%. Let's just say it's about 40%. And I'm in that group. I'm a card-carrying member. But I really wanted to also take a dumb liberty and share with you an equally crude but useful epidemiological classification measure for obesity. It's called abdominal obesity, and it's really just an expression of waist circumference in males and females. If your waist circumference is in excess of an a priori fixed threshold, then you're considered abdominally obese. But in my lens, there are actually even more intelligent and comprehensive classification approaches to obesity. Sarah's going to tell us lots more about that, and we'll be better off because we know that. One more slide. So I talked to you about knowledge is power, and all of this great information that they're there. So Dagny and Greg delivered. We're better off because of that too. We know more, and we can be better at our jobs. But these two gals, Maureen and Morgan, have been rolling up their sleeves, digging into the claims data, which I did want to take just a quick moment. Last greeting and salutation, but Mary Fields and Chris White, right here in the back, are our partners working with the New Hampshire CHIS, also known as our claims data. It is an incredibly robust, invaluable source of healthcare information, dare I say it, healthcare insights that empower much of the work that we do. As a note, hot off the press, we have the first 2 quarters, right, Mary, of the CHIS, right? So as of the first 2 quarters, so first half year of 2025, that's the year we're in right now, and claims data vernacular, that means hot off the press. There's nothing more current than this right now. And New Hampshire probably leads the way in the management of our claims data. And Mary and Chris and Morgan and Maureen's and Alex Feldwebel's, you're not getting away with more acknowledgement, Alex. Their work ensures that. Most people don't know that. I didn't know that till I came to the insurance department. I know it now, and I'm remiss to not share it with you. But $650 million at the halfway point for 2025 in allowed amounts, which is gross of rebates, as Dagny pointed out in her presentation. One thing we saw in the annual hearing data was that our observed rebate percentage, aggregate rebate percentage for GLP-1s is about 50%. Some sources say other. I want to hear what Sarah, we have a lot of Sarahs in the room, all right? So because I'm so bad with names, we try to identify speakers named Sarah, and we did good with that. So, but Sarah has a lot to say about that, and I wanted to ask my understanding and yours on that. But we took that proportion, that reference proportion of 0.5, right, about the average rate of rebate in the annual hearing data from our carriers for plan year 2024, and applied that to the observed aggregate allowed amount of $650 million. That's $325 million. If you crunch the math or do it up on your phone, you could probably do it in your head. But I saved you the dumb English, and that's about $325 million of net expenditures, net of rebates in GLP-1s halfway through the year. That's a lot of money. I just, as a liberty, I report the cost sharing too, because a colleague of ours, Lucy Hodder, she asked that question, and I thought it was a salient question, and I thought it one that I didn't ignore, I kind of just forgot about. And that's an example of how our colleagues can interact with us to help make our message stronger and further encompassing and further reflective of some important attributes of the work that we share in state government. But the cost sharing is not trivial either. Cost sharing is deductible, co-insurance, co-pay. But you're in over $21 million of cost sharing at the halfway point, meaning just if you assume linearity, that the first half of the year is going to be exactly the same as the second half of the year.
And that's not a direct assumption.
If you assumed it, though, you're talking $41 to $5 million of cost sharing to New Hampshire citizens for just this therapeutic class, and you're talking close to $750 million of net expenditure of rebates for this one therapeutic class. That's a lot, and it took me a lot longer to talk about that than I planned, but that's important information. The last slide, Morgan, and I'm going to refrain from saying too much about this, but this is important to me because how insurance works is we share risk, pooled risk. I should know much more about that than I actually do this much time. I haven't been at the insurance department, but so I just wanted to put that up there without saying that much about it. Because we share risk, when you share something, your responsibility is different compared to when you run your own, right? You're sharing food, or you're sharing a car, or you're sharing a hotel room. You have to agree on certain things, right? So this concept of shared risk with regards to obesity, breaches upon the concept of moral hazard. Let's not get too deep into that. Rather, I just wanted to make you familiar with this term called the obesity externality. Externalities mean that I'm not part of that market, but I'm either harmed or I benefit from that market, right? So this talks about the role that obesity plays in incurring excess cost to the non-obese population. Henceforth shall be referred to as the obesity externality. I've not adjudicated my position on this, and I'll not ask you to. Rather, just merely wanted to make you aware of this mechanism that works somehow, some way, maybe unbeknownst to us, maybe not, but awareness, knowledge is power. Having awareness of this can help us to optimize how shared risk and pooled risk can work well for everybody in that pool. Okay? Thank you for that time. So I think the way we want to start is by having our clinical perspective. So from Dartmouth School of Medicine, talk about clinical perspectives and clinical utility and all those other things that we brought them here for. Okay? Yeah.
Dr. Finn, come on.
Yeah, I think he does.
So there you go. There's your Dr. Az's Unchained session. His BMI is irrelevant to me. The man's energy level, though. I need to understand how you get that. In any event, we do have a little bit, one last housekeeping item, which is a clarification on definitions of things. As you mentioned, we've got a couple of Sarahs in the room. And so, Sarah Finn, I'm going to refer to you as Dr. Finn. That's right. I figure you'd worked hard for that. Many years of schooling. Ought to show the respect and the deference. Dr. Ez, of course. And then Sarah Eamon, you're not a doctor, are you?
No, you're not.
Thank goodness. It would have been like a scene out of Airplane.
What I think, doctor?
That was post or pre-1985. All right, Dr. Finn, take it away.
Thank you guys so much for having me. And I also want to introduce Emma Dean. So she's the other half of my presentation today. So I'm so honored to be here. Thank you, Commissioner. Thank you, Jason and team, to allow us to speak today. So I'm an obesity specialist. So that's really what the hat I need to wear today. And I'm just going to go over a little bit about obesity as a disease. And for me, it grounds me to start with patients because that's what I do all day. I know we're talking a lot about a population-based level, but I think it's really important to highlight that, we talked about the prevalence of obesity being so high. Right now in New Hampshire, it's about 33%. And the cost of these drugs that are effective are very expensive. And so in New Hampshire, we call that a wicked problem. And so we're going to talk about how this wicked problem is affecting all of us. But let's go back to the patient. So this is not really Tiffany, but or the name Tiffany, but I have a patient who came to see me in 2018. And so as I start most of my visits, I kind of pay attention to my patient, and she's just sitting there kind of arms crossed, not making eye contact with me. I'm like, so Tiffany, how are you? So great to see you. What are you hoping to get out of me today? And she looks at me with disdain and says, I don't know why I'm here. My doctor said I had to come here. I don't want to see you. I've been doing this since I was age 5. I started dieting. So please just get this over with, basically. So that is when I listen and I say, okay, Tiffany does not really understand this disease. And so that is actually my first step in understanding this and working on this with Tiffany. So I say, Tiffany, let's look at my tool, which is a weight graph that we have here in Epic. And Tiffany tells me, I've tried all the diets, every single diet. I've spent so much money and it's just so frustrating. I do it and I'm able to lose a little bit of weight, but then my body fights and I'm getting back up. And so nothing's working and I'm just giving up at this point. So what I like to bring up is, Tiffany, let's look at this. So hearing this and seeing this, I just want to point out that this is not normal, right? Your brain is trying to protect a too high fat mass of 365 pounds. So that BMI calculation is 60. And when you came in to see me, Tiffany, we not only just did your weight and your height, but we looked at your body composition. And we found that your body composition shows high fat mass of about 60%. And also your stored fat in your viscera, so that abdominal adiposity. And Tiffany, that's not normal. Your fat cells are becoming dysfunctional. The brain is trying to protect this too high fat mass. And with you in particular, the fat cells now have gotten so big that it's starting to store fat in your liver, and you have fatty liver disease. And that's not normal either. We shouldn't be storing fat in other organs. So what we're going to talk about today, Tiffany, is that I am not going to just put you on a diet. I'm not going to put you on an exercise plan. I'm going to talk about how we can re-regulate your brain to accept a lower fat mass with our different treatment. And so Tiffany kind of looks at me and says, okay, I'm listening. And so then we talk through what we're going to do. So Tiffany starts our lifestyle program, which every patient does for any intervention we do to treat obesity. But we also started oral medicine called Phentermine, which has been around since 1959. It's very affordable. And Tiffany does well. She has about an 8% total body weight loss. But here, as you can see in 2019, she comes back to see me and says, I'm doing all that you're saying to do, all right? And nothing's happening. I'm just stuck. What's going on now? And so this is where I say, Tiffany, I'm so glad you're here. Let's just remind you that you have a disease state. Now your brain is trying to protect this weight of around 345 pounds, okay? And even though you're doing all the things with your lifestyle and taking this medicine, your brain is still fighting to kind of maintain this weight. So over the course of our time together, Tiffany keeps trying different various therapies. We try to work together to try to get her brain to accept a lower fat mass, but she doesn't respond to them. And actually she has a lot of side effects. So, but during this time, Tiffany gets sicker. She gets endometrial cancer. And her surgeon calls me and says, we can't actually do surgery because her BMI is too high. Okay. So she has cancer in her body and we can't help her. So at that point, thankfully, science has helped a little bit. And in 2022, I have a new option, which is tirzepatide. Okay. That's one of the GLP-1's GIP options. And Tiffany and she starts that. And as you can see, over the course of 4 years, her brain is now allowing her to accept a lower fat mass. So she's 220 pounds now. She's in remission from her endometrial cancer, liver disease, and maintaining a BMI of 35. That's, hiking in the woods, doing more activity is a really great success story. So what I really hope I can do is advance my slides. Because video. Is what I like to explain to patients is how obesity is a disease. So we talked about the definition of obesity, which is really important that we talk it through. There's actually like 6 definitions of obesity, depending on where you want to look. And we have a definition of obesity actually since 1959 from the WHO. But how I like to describe it as patients is it's the brain is the problem. It's dysregulated. It's trying to defend and protect a too high fat mass. And the problem with this disease is not that patients can't lose weight. They do, and we see that. That's why there's a $1 billion dieting industry. So patients can lose weight. The problem is they can't really maintain that. And the reason for that is something called metabolic adaptation. So I talk about this as like a thermostat. So say our room today is 65 degrees and it's in the middle of winter and we open up those windows. So that cold air is going to come into our room. The temperature is going to go down. So then our thermostat is going to sense that and kick in and pump out heat. And then over time, the room temperature is going to come back to 65 degrees. So that thermostat analogy is actually the same thing for what our brain does for regulating body weight and fat mass. Okay. So when we get to that certain threshold where that fat mass is becoming too low, the body goes under metabolic adaptation. You become more efficient at what you're doing. And you get hungrier, those hunger hormones start increasing, more thoughts of food or food noise, which is actually a appetitive symptom of our disease of obesity. And the body weight goes up. Okay, so this is why it's really hard for patients to maintain with doing things like good, healthy lifestyle, even doing our successful things like medicine and surgery, is because the brain is really fighting this. So this is just a summary to just show you how complex this is. In the brain itself, in your hypothalamus, is where your step point is, that regulating part of the brain. And the GLP-1s that we have, GLP-1 is a natural gut hormone, but the medicines that we have work on the brain itself to help you with that regulation So the brain is allowing like Tiffany's brain to accept a lower fat mass. And it does this by making you feel less hungry, feel more fullness, and also helping with metabolism. So this is a very, very complex interplay system, but I think it's important to just kind of give you a big overview. Okay, so what are some obstacles to obesity care? There's a lot, and this is just my top choices here. But the biggest one I see in healthcare is that we really don't treat obesity as a disease. So although there's a definition, there's a way I can diagnose, I can look at patients' symptoms, and they offer them treatment. We're not doing that, okay? So when a patient comes in and they see their primary care doctor and they get a height and a weight, they might leave that visit with a diagnosis of obesity based off their BMI, and there's no conversation about what that means. What do I do about it? How do I treat it? It's just, in their chart now is this diagnosis of obesity. So we don't do our job to diagnose this accurately and also talking to treatment about appropriate treatment. But then in the insurance realm, we can opt in to cover these drugs or opt out of coverage, and not just drugs for obesity, but also bariatric surgery. And I can't think of another disease state where we can opt in and not opt out of treatment like we can with obesity. So there's tons of misinformation and bias in our society. Patients blame themselves, like Tiffany. Come to find out, she really blamed herself and shamed herself for having this disease because doing all of those things weren't working, and then she blamed herself. And we do have really good data to support when patients do that, have more internalized weight bias, they're sicker. They actually have more stress, and their disease of obesity can get worse. We're here to talk about costs. So once again, this is the wicked problem. These effective medicines, but they're really expensive. And I don't have my magic wand to to make these drugs more affordable. But that is a big piece that we're fighting right now. We see a lot of other health conditions as more pressing than obesity. So although obesity has underlying for about 200 different medical conditions, we don't really treat it that way, okay? And so we put a lot of precedence into heart disease and cancer treatment, which is so important. Those are the two top causes of death in our country. But obesity is actually, if a patient has obesity on top of those other conditions, treating obesity can reduce that chance of heart disease and cancer risk. And then there's a lot of provider factors. So myself, when I was in school, I got a CD on nutrition that I was supposed to watch in my free time, okay, as a medical student. That's not okay. I had to learn how to do this all after my training on how to take care of patients with obesity. So we need to fix that. But there's not a lot of time and really not a great training from the medical end on how we talk to patients. And then at the end of the day, there's tons of patient factors. I would say there's a difference between having obesity as a disease and also having our society desire for thinness. It's a very different thing. Disease has end-stage chronic organ changes where if somebody wants to lose 20 pounds, that's a very different situation if they don't have obesity. And then also there's so many problems right now with compounding drug. That is, not FDA regulated. We don't recommend that in the obesity medicine world. But patients are desperate and they don't know what else to do. And there's so much commercialization. It's like, where do I go? And that's really, we're not doing a great job to serve our patients that way. So what have we done at the Weight Center at Dartmouth Health is we've really had to redesign how we do things. All right. So what we're starting is a rapid access clinic. So basically patients can come in to us quickly. We can appropriately diagnose them and then offer them the right treatment choices. And GLP-1 therapy is here at the top, but not every patient needs a GLP-1 therapy, right? That's just one of my many tools that I offer my patients if I have that with insurance coverage. So if a patient is appropriate to start a GLP-1, we will do that, but they're going to go through a pathway that has a lot of support, checking in monthly with our nurses, dietitian support, because how you eat and how you drink and how you move is really important on how you do on these different therapies. And we have to really guide patients the right way. Some patients, like Tiffany at the beginning, respond to oral drugs that are cheaper, that have been around a long time. And so not every patient needs a GLP-1, especially those patients that are not as sick. For our patients that might have more disease states, endoscopic or bariatric surgery might be appropriate for them. But once again, since I've been doing this job, no one comes to me and says, please give me surgery. Okay. But what they tell me is, please help me. Please help me. Because living with the disease of obesity that's not as undertreated leads to a lot of suffering. We have found that undiagnosed disordered eating is a big problem, especially with these kind of patients getting GLP-1s from a doc in a box and med spas and different things like that. And so these can be two different diseases. If we don't treat disordered eating or diagnose it, while we treat obesity, that disordered eating could actually get worse. So at Dartmouth Health, we have a reset clinic to diagnose this and help patients appropriately. And finally, everyone needs lifestyle, all humans. But as we're using this for our different therapies, it's really, really important. Lifestyle is a tenet of all that we do. And anything that we study in obesity medicine with drugs, devices, surgery, all is lifestyle. A lifestyle arm is always part of that. And it's a really intensive lifestyle arm. So we can't deny the importance of lifestyle therapy. So this is just a summary of who we are in our team. We have a lot of great experts that have different, is multidisciplinary team to help support our patients because it really is a team effort here. I'd like this summary here to just describe how complex it is to treat patients with obesity. So when Tiffany sat in front of me at our first visit, I actually had no idea how she was going to respond to any treatment that I prescribed. All right. That is frustrating for a patient, right? They were like, you're putting me on this therapy and you don't know if I'm going to respond or not. So we're still in the beginning stages in obesity medicine on how to, at a genetic level, say which patients are going to do well and which patients aren't going to do well with our different tools. But we're not quite there yet. And so we see a bell curve with anything that we do in obesity medicine. There's a group of patients that don't respond, so that's called non-responders. There's a group of patients that respond like you study in research, and there's super responders. We actually have no way of knowing which group those patients are going to be in until we start treatment. So it really is important that we monitor, and if they're not responding to a treatment, we switch treatment. We don't just keep them on a therapy that's not working for them. So that's a really important piece, I think, for us to get today. All right, so I'm going to pass this off to Emma.
And hi, I'm Emma Dean. I'm one health economist, one of the many in this room. I know we're going to hear more about this later, so we'll just be very brief. But after we heard about a lot of the benefits of these medications, wanted to talk about the costs, which are what we've been hearing about today. And as we'll hear from the absolute expert, these GLP-1s have been considered, relatively cost effective. But we recognize that that does not necessarily equal affordable to the system at current high costs with the high demand of these drugs right now. And so when we think about, just as an example, projected Medicare spending just for covering these drugs, even including accurate net costing, would be $3.5 to $6 billion annually. So you can just imagine that enormous shock to the system to cover these drugs at current costs for all the patients who could benefit from them.
It's such a...
Thank you. Oh, one back, sorry. And so, of course, one of the trade-offs that we talk about here is, of course, these have enormous health benefits. Those health benefits are great for patients on their own, but they also lower costs in other arenas, which I'm sure we'll also hear more about next. But, this weight loss can also be associated with reduction in weight-related comorbidities and other conditions that tend to come along with higher weight. And these, of course, not only have these enormous benefits, but they also have these long-term economic benefits to the healthcare system. One of the issues, though, with commercial insurance and covering these drugs for patients is those benefits tend to come down the line. We have patients switching commercial insurance regularly, oftentimes, within 5 years is very common. And so you cover a drug, and then you don't actually see that payoff by the time that patient has already switched insurance. And so this we understand and recognize that makes it very difficult for insurers to cover these drugs, and this high short-term cost does, though, have very important long-term savings. And I know Jason had mentioned this, and I'm sure Sarah will mention this, but one thing we always want to talk about when we look at projections and total spending on these GLP-1s is that list cost is not net cost here. I had about a 40% reduction. I heard 50% from you, and I think you have the latest numbers, the latest and greatest. So we do need to consider this. And when we talk about some of these policy options, we do have to consider that we expect this net price to potentially drop as more competitors enter the market. though it might not be visible when we look at these list price and some of these projections that don't take into account this accurate pricing information. So what Sarah and I are going to do in the last few minutes is talk about how some insurers are currently covering these drugs for some of the patients, recognizing that they can't cover these drugs for all patients. So here are some potential strategies that people either have taken or have proposed to take to lower the cost and potentially cover these drugs for the patients who can most benefit from them.
Great. So the first one is enhanced clinical criteria. So the policy is really looking at BMI. So BMI, once again, is not a great individual tool to assess obesity, but it's an okay population tool. And I didn't mention this earlier, but a BMI of over 35 is very much correlated with abdominal adiposity. Okay, so the definition of obesity. So a BMI of 35 is likely you're going to get somebody with clinical obesity. So this idea would be taking patients with higher BMIs. So we talked about that's we call class 1, class 2, or class 3 obesity, depending on where the BMI is. And considering that with coverage based off also having different complications with other disease states. So we've used this approach before in bariatric surgery. Okay, so our bariatric surgery indications are very similar. So they're a BMI of over 40 or a BMI of 35 with complications. And I like to bring this up that we talked about the cost per year for patients who have obesity, but it actually, if you think about looking at it from different BMIs, there's the 2,000 cost for a BMI of 30 to 35, but as you can see, as it goes from 35 to and up to 40, $8,000 a year with BMIs over 40. And interestingly enough, if you look over year 4, so patients who have obesity that are not treated with these higher BMIs, they get sicker, okay? And then their cost goes up. So can you see that after year 4, how that cost now is going over to $10,000 a year? So making consideration based off how sick our patient population is with their disease of obesity makes a whole bunch of sense to me. And I didn't describe this earlier, but we have this Edmonton staging system. So it's not just looking at BMI, but it's actually like looking at the medical, the physical, the mental health components and seeing what kind of end-stage disease do patients have. And that's a really important tool also just to say how sick our population is. I want to just bring up that lifestyle is so important here, and giving patients options to do lifestyle in addition to the medicines is essential. And I do want to bring up with you, Jason, about exercise, the importance of strength training. We have a nurse kinesiologist on our team who highlights this with every patient, the importance of not losing lean body mass as we're treating obesity. And then finally, what we're doing here at Dartmouth Health is we're starting patients on the GLP-1 therapy and then transitioning it over to primary care once the patient's stable. So we are, kind of helping the titration, making sure the patients are appropriately titrated for these drugs. Reminder that these GLP-1 agonists, they take about 6 months to get up to the max treatment dose. So if you just see a patient prescribe a GLP-1 and see them back in 6 months, they're going to be on month 1, which is not an effective treatment dose. They really need to be treated the right way here. So the next policy is time limited or weight target based caps. So this is basically setting a time limit on being able to get the therapy. And I'm going to bring this up. I'm just going to compare this to high blood pressure, for example. Okay. So say you go to your primary care doctor, they diagnose you with high blood pressure, you do the lifestyle, you come back, blood pressure is still high. So your doctor says, I'm going to put you on a blood pressure med. And you're like, great. Well, maybe not great. You just probably don't want to be on a med. But then you are on the med and your blood pressure comes down. Okay, so say year 2, after your blood pressure is controlled, your doctor comes over to you and says, oh, sorry, we have to come off the drug now. It's been 2 years. You'd be like, why? My blood pressure is controlled. I feel well. Why are you taking me off my therapy? Well, I want to highlight that this is what we're doing for this disease. We're not treating this like a chronic disease, like high blood pressure with obesity. If we just give patients an opportunity to be on a drug for 1 or 2 years, that metabolic adaptation is going to kick back in and the body is going to fight to regain their weight back. So this is a trial, the Step 1 extension trial that was one of the drugs, semaglutide, to treat obesity. And as you can see, the patient over the course of 6 to 8 weeks was able to get to a lower weight of about 17% total body weight loss. But then the drug was withdrawn from the patient. And very quickly, within usually it's like 4 to 6 weeks, the weight starts going up. And since I've been on the other end of hearing about this experience from patients, it feels really bad. You have lots of food noise. You have lots of hunger. You feel so frustrated. You're doing all the things you were doing before. It's just the weight keeps going up and up and up. And so in this arm, after 9 months, the patients had regained 10% of that total body weight loss. So this is metabolic adaptation. Okay, that's the brain trying to get back to that too high protected fat mass. And that is why we need chronic therapy. So some patients don't need weekly injections forever. Okay, there is variability here in treatment. So in our practice, when a patient gets to maintenance, we can do injections every 2 to 3 weeks. So my patient, Tiffany, she's actually on that plan. She's not taking weekly drug. Pediatric people, kids, I see some adolescents, and they're so responsive to different medicines that they actually don't need to be on them chronically, which is really fascinating. So we start them because we're actually treating the disease state at a much earlier age. If you think about taking care of a 12-year-old versus somebody who's 80, okay? And then specialists, I just want to bring up that as a specialist, we understand how to titrate these drugs, how to counsel patients on these drugs, and we get the patients to the right treatment dose. And that really is because we know how to do this. And so specialists do have better outcomes.
Then I wanted to talk about two of the other potential policy options that are more in the insurance side. And one is formulary management. So this could be only covering one brand in particular of these GLP-1s. Oftentimes includes things like step therapy. You step through earlier therapies to get to the more expensive medications. There are some patients who do benefit from having one particular brand over another, still kind of working to understand the reasons why or have less side effects on one versus another. However, overall, we completely recognize that this can actually lower costs to the point where an insurer can potentially cover some of these GLP-1s versus none, particularly for obesity. So as an example, Massachusetts Medicaid has successfully implemented this approach and been quite open about the fact that this is how they were able to negotiate a lower price by only covering one brand, and at least in the short term will continue to only cover one brand to maintain that lower price to the department. There is a kind of limited evidence on abrupt switches. So if that brand were to change, one recommendation on the clinical side is that, have there be a little bit of a window to allow a patient to have time to switch from one brand to the other and kind of ramp up there. So as opposed to a direct, immediate switch. Of course, acknowledging step therapy is necessary, not just for these drugs, but for all high-cost medications. It can, of course, delay access, but this also really helps identify the patients who truly can benefit from this drug, who could not benefit as much from other therapies. One clinical consideration here is that some of these earlier therapies do have contraindications that can be quite serious. And so when you have these step therapy in place, it is good to have some exceptions. So for instance, if a patient who has epilepsy can't take an older version, they might be able to opt out of this particular step therapy requirement. And then very related is this sort of price negotiation and rebating that we know goes on behind the scenes with the PBMs and the insurers. And there might be unique contracting arrangements. This is not the only high-cost medication we've seen in the past, but there are different ways to do this. One is to actually support patients who are not covered through some sort of out-of-pocket navigation programs to help them work with, the manufacturers and their patient assistance programs. Another are things like volume-based rebates or subscription models. These can expand patient access in theory. So in this, you paid one overall cost. As many patients as are appropriate to be treated will be treated for that total cost. There are challenges here. One historical challenge has been we've just had shortages, right? And so that will kind of make this very difficult to implement in practice, same as the single coverage requirement. Also, just practically, a lot of these manufacturers, are they going to be willing to do this? One thing they're concerned about is there's this Medicaid best price rule, which means that if I give you in the commercial insurance a lower price, an average price across a bunch of patients, I then have to also provide that to some public payers. We do want to note, though, that there are 39 different GLP-1s currently in development. What that means is that we're going to see a lot more competition on the GLP-1 market. We know at least from other high-cost therapies, and I have an example here. This is from hepatitis C. So what you see here, this is list price in net price. This was right when Sovaldi launched. You see there was basically no rebate there. As competitors entered the market, you started to see that net price for Sovaldi decrease and for all of these medications. We expect the same exact thing to continue to happen in GLP-1s. So this does give us some, I guess, forward-looking promise that potentially, even if we don't see those list prices drop, the actual net price that's negotiated will go down over time. Make this more affordable to insurers.
Right? So finally, we just feel very honored to be here because I think as I feel as an obesity expert, it's my job to advocate for my patients that I see every day. But I need to do that working with all of you who are making decisions. And so I just really want to thank you for allowing us to be here to have a discussion. And I just really look forward to really doing this well in New Hampshire. We're already kind of killing it in our state from what I heard earlier. So let's do this well with obesity too. So thank you so much for having me come.
Oh, thank you for informing our citizens and all of our policymakers and attendees. So I'm thinking we should refrain from asking questions because I've got a dozen and one, but I'll for sure do that until we hear from Sarah Iman from ICER. And wait till you hear that. And so try to keep your questions right up down. And you could, for remote attendees, you could put the questions in chat and we'll have somebody from the insurance department pose those questions as appropriate for you. But I want to get Sarah Iman up here because she's been sitting patiently since the beginning of the hearing. And I know you heard from our other Sarahs about some of the work that ICER does. And this is that other part, that second part of the story. How do we balance the cost of these obviously important and highly valuable therapies to treat a condition that is not trivial? So Sarah Iman from ICER, the Institute of Clinical and Economic Review.
Jason, it's a real pleasure to be here. My thanks to the commissioner and to Jason, to Morgan and to Maureen for the opportunity to share a little bit. I am worried I am going to wildly disappoint you. Because if there was an easy way to ensure affordable access to GLP-1s, we'd be doing it. And the reason we're having this conversation is because this is hard. This is hard because we are managing the moral obligation that we have to the patient in front of us who has the opportunity to achieve their health goals with these amazing new drugs, with the fact that we pay for healthcare with all of our dollars. And when we have those two things in tension, because the current net prices of these drugs represent such a budget challenge, that's when we have, I'm sure Sarah has so many stories of what she's had to go through in her clinic to try to get access to these medicines. And it's not that the insurance companies or the purchasers don't want to help the employees and their members who have obesity. It's they are having a really hard time figuring out how to do so in an affordable way. So I could just sit down now and be like, okay, sorry. And some of what I will cover quickly here, Emma did a fantastic job of already highlighting a bit. Just a moment of who we are and why the heck I'm here. ICER is an independent, nonpartisan organization that exists to help the system know what is a fair price for what we pay for in the healthcare system. We do most of our work on prescription drugs because the government-granted monopoly that exists during that period of grant creates really screwed up dynamics in the drug pricing negotiations, right, and forth. And so our work is meant to say, hey, what if we, radical idea, we actually price drugs based on how much they help patients do, how much they help them feel, to improve their quality of life, live longer if it's a life-limiting condition. And what we find with most of our work is about 30% of the time, manufacturers are pricing their drugs in line with the benefit that they can prove through the data. And that means about 70% of the time, they're not. What's so interesting about where we are with this particular issue, and by the way, we just love to talk about our funding every time we're here, because anytime someone's talking to you about what should happen and the change that should happen in the healthcare system, please go look at their funding. Just go look at their funding. So ours is available if you're interested.
What's really interesting here is that we have effective drugs that are cost effective, as Emma mentioned, but they represent this budget tsunami that we've never experienced as a healthcare system. What we see is that 10 to 50% or higher premium increases are expected in our healthcare market right now. By the way, good job, guys. Like, everyone needs to be looking at what New Hampshire is doing. Your rates of growth are a lot better than what we're seeing in other parts of the country. But what I get told when I'm talking to large purchasers, whether they're big, large employers or large state purchasers, Medicaid departments, they're freaking out at the rate of the health insurance premium. And they're challenged to make really difficult decisions about what they're offering based on these premium increases. And every single one of them is talking about the cost of GLP-1s as driving the premium increase. It's not the only thing. We've heard about outpatient costs going up. I've heard about complex care. I've heard a little bit about how delayed care from COVID is sort of catching up a bit with the system. But these GLP-1s are representing a significant challenge to keeping health insurance affordable. And the current coverage patterns are really a hodgepodge. And so you've also got a system where, unlike other conditions where there might even be insurance mandates for coverage, right? There are protected classes in Medicare where you have to cover the drugs for certain diseases. Medicare is actually allowed to not cover drugs for obesity. This goes back to legislation from when Medicare first got the ability to pay for medicines, which was not that long ago for those of us who do remember Airplane, thank you, and things that were happening in the 80s, that they just got the ability to pay for drugs in the early 2000s. And this was part of the negotiation for how that benefit was going to be affordable. And at the time, we can all remember the stigma that was associated with having overweight or obesity. It was willpower, and they were considered cosmetic. And so Medicare is not actually allowed to prescribe or to pay for drugs for obesity. There's a little bit of a loophole. If you have obesity and a risk factor for cardiovascular disease, you can get coverage because there's additional indications for some of these drugs for treating cardiovascular or for cardiovascular prevention. There's legislation pending to do this, but every time the Congressional Budget Office scores this, everyone freaks out because the cost to the system is very, very high. So there's rumors right now that the Trump administration is going to try a demonstration project to expand access to these drugs for the Medicare population with obesity. So keep an eye on that. I expect we're going to know whether or not that's a thing probably in the next 4 weeks, by the end of November at the latest. Medicaid is also exempt from covering these drugs. For those of you who know the Medicaid department, they are required to cover every drug that is offered from a manufacturer that participates in the Medicaid drug rebate program. But it's the same statute that said Medicare didn't have to pay for drugs for obesity that says Medicaid does not. But 13 states, and this number changes daily. It could be 12 now. It could be 15. I didn't Google it this morning. Are offering this. We heard that Mass Medicaid is doing it. But this number, when I first started making this presentation, was 16, and now it's down to 13. Because guess what? 3 states stopped because they couldn't afford it. So commercial plans, 30 to 40%. You're more likely to have access if you are white collar, honestly. The large commercial insurers, purchasers that are more in like retail and hospitality are less likely to offer this as a benefit because, again, it's just considered something that's more expensive and makes their plan costs go up. Now, I've said all of this, but what do we actually do about it? I don't know. Emma had a couple of these on her slide. We did a white paper where we spent a year talking to experts and convening pharmaceutical companies, pharmacy benefit managers, payers, and purchasers, and we're like, what can we do? And this is the list of options that we came up to, with. You can see the link below. You can dive deep on some of these options. Some of these options are market-based. We could demand bigger discounts. We're already seeing 50% discounts. These drugs are wildly cost-effective at that price. It's still a budget tsunami just because of the mass of the eligible patient population. So we could just continue to try to negotiate lower prices. We could do what some purchasers have done, which is not cover them until the prices come down. It's not awesome. I love it. I mean, it just creates a ton of inequities in the system, because then with the direct to purchase options, you're basically saying, well, people who are of means can actually achieve their health goals when they have obesity, and then people who can't. I mean, that seems like really bananas, but it's a thing that's happening. We've heard about the different prior auth and the formulary management. There have been some conversations about limiting prescription to centers of excellence, so the work that Sarah and her team do. The problem there is also just an accessibility one. There just aren't enough Sarahs in the world. I think that's generally true, by the way, especially those with an H. But I think that we're roughies, so that too. I think that's one way that some purchasers are thinking about handling this, because then they know that they have a higher, their employees have a higher chance of success because they're getting managed by the nurse expert. They've got a nutritionist. They know they can call someone to help them manage their side effects. And it's really tough to expect our primary care system, which is already under a ton of strain, to also develop that skill set. So I love what you guys are doing with start with me and then go to the community. Carve-out programs, we didn't talk about those today. That's something interesting that's being talked about, which is this idea of, I'm actually going to take this out of the health insurance system. So this would be if I'm a big purchaser, and I'm going to pay this vendor to do it. And so there's been some preliminary data here that are encouraging. They're not just, it's not row or hims or hers. Like, don't think of it that way. It's, let's evaluate the type of obesity that you have. You might respond to older medicines or a different intervention. It helps with lifestyle management. It helps with weight loss, with side effect management. What's really interesting for purchasers and why they love this is there's some fixed budget that they are paying to the carve-out company for this, regardless of the cost of the medicine. So this gives budget certainty to certain purchasers instead of the, oh my God, if everyone goes on this GLP-1, my PMPM is going to go up $26. And there's some shared savings approaches. This is one to watch. It's still pretty early to know how helpful that'll be. On the right-hand side, and we'll spend a lot of time on this, because when we do our policy reports once a year on a topic, the year before this one was how to pay for gene therapies. This year, this most recent one was GLP-1s. Our next one is the accelerated approval pathway from the FDA. We often have a section on things that the federal government can do. I think that we should all have modest expectations about there being some federal action on this. I did mention that we will potentially see this demonstration project, and that's going to be very interesting to watch. But there are some more, I'll call them radical ideas here about how we could rethink paying for obesity treatment, because Emma also made this really great point, which is most of the time, the benefits that when we say they're a great deal from a long-term value perspective, that's over a lifetime. The benefits accrued at the Medicare department, the budget, because patients are having fewer heart attacks, strokes, less cancer. And so if we want our commercial insurance to pay for something that Medicare then benefits for, then maybe we need like a little federal carve-out or a subsidy from the federal government to the private insurance market to help afford this very cost-effective therapy in order to have that wonderful benefit, not just for patients, but also from a budget perspective. So where are we? ICER did a report back in 2022. It was mostly focused on Wegovy. That's semaglutide. Zepbound tirzepatide had not been approved yet, so we didn't really have it totally in scope. But we are updating that report right now. The spoiler alert here is, because the updated report comes out next week, but our draft report was out there and the results are not changing dramatically. They are wildly cost effective still. And we are now seeing, with the 40 to 50% discounts, prices in line with that long-term value, and they are still representing an unbelievable budget tsunami. There are some ways to model what the price would need to be in order to see cost savings in a period of time, maybe say 5 years. Just a quick sort of difference between cost-effective and cost-saving. Cost-effective means we're paying more, but we're getting health in a magnitude that we are happy about as a system. Cost savings means I'm spending this money and I'm saving money on a whole bunch of things. At the current net prices, these drugs are not cost saving, they are cost effective. That's still good, and we should celebrate that. There is a way to kind of look at the budget impact math to see how much you would pay as a purchaser in order to achieve cost savings over a period of time. It has a lot to do with what you'd be displacing. Like if you're spending a lot of money now on the older, less effective drugs like Qsymia and Comparative, then you'd actually see some cost savings if you paid around $300 a month for the drug, just as like a reference point. But if you're not spending a lot of money on obesity management already, that price would actually probably have to be lower. So don't quote me on those prices, but just to give you directionality of, there is a way to say at what point would these drugs be cost saving. The net price would have to come down. Tune into our public meeting on November 13th. I'll be moderating a policy roundtable with both manufacturers. Lilly and Novo will be there, clinical experts, payer representatives, so that we can all sit around the table and say, okay, let's fix it now because we are running out of time. And the patients really need us to figure this out in a way that is affordable for everyone. Thank you for the opportunity to be here.
Wonderful. So Andrew and AJ are going to set up the room for our panel. We're going to go a little bit over, but not too much over for the panel. I don't want to be hearing too much food noise amongst the audience if we go much past noon. I did want to also acknowledge that I had given short shrift to Emma Dean at the outset. For a reason that hopefully all of the doctors in the room can appreciate, which is I couldn't read my own handwriting.
Nothing.
So, again, as I think was mentioned, Emma is a doctor, assistant professor at the Dartmouth Institute for Health Policy and Clinical Practice. So thank you so much, Emma, for being with us. If you'd like to come on up and have a seat, get the party started.
I'm really,
Yeah. Wonderful. You going to join us?
yeah.
All right, so I'll say at the outset that I put some questions together in advance of the presentation, and you guys did a phenomenal job of hitting a lot of the things that I thought would be interesting to dive into. So there may be a question or two that expands upon your presentation, but some of it might just be, I think, something that we should particularly focus on and maybe give you the opportunity to add some more detail to. Obviously, some of these questions are tailored to some of you more than others. They're always open to you, but if it's outside of your wheelhouse, that's totally fine. And appreciating that what we're talking about here is so new, I don't know yet is a perfectly acceptable answer. So in any event, do you want to switch off questions, or what do you want to do?
No, this seat here, just as a note, I actually intended, and you mentioned that in your introduction, for this world-class researcher. That was Dr. Susan Roberts, who is the Vice Provost of Research at Dartmouth Medical School now, and she's the former director of the Energy Metabolism Lab at Tufts University, Tufts Friedman School, the school I went to and I teach at. I'm going to refrain on putting myself in that seat right there, just to avoid any conflictual messages or any conflict of interest, and I want to hear your viewpoint. So I just wanted to kind of point that out. We did get questions from several folks yesterday that, in lieu of any other questions from the present and remote audience, I would love an opportunity to phrase them. So I just want to make that clear, and we want to hear from you.
Absolutely.
Does anybody here in the room have a question? Okay.
It's great. Yeah, save time for that as well. Nobody wanted to jump up in the seat and become... That's all right. All right, so I'll kick things off here, and then we'll do a little bit of a mixture. We'll get some audience questions and some questions that have come in via email. But the first one probably more directed toward Dr. Finn and Emma. How would you evaluate the impact of the availability of these medical therapies on patients or population of patients' motivation to use lifestyle to manage, first, a healthy BMI, and secondary, risk for other obesity-related conditions? That was a very intelligent question, which tells you that Dr. Aziz drafted that one for me.
So what I want to say to that to start is when we have patients come to us, I think I've never had a patient tell me that they don't want to do lifestyle. Okay. I think part of the limitations of doing lifestyle for a lot of patients is that hunger, craving, food noise, the appetitive symptoms of their disease of obesity, or they have physical or mental limitations that allow them to do lifestyle. So I want to bring that up that when we use the right treatment for the right patient to treat their disease of obesity, their habits change. And we find that so dramatic. Like with the GLP-1 therapies, not only does it work on that regulation part of the brain, but it also can work on the hedonic brain. So people actually have different cravings for different foods, like vegetables. And so I just think that's really important that we talk through that. I think lifestyle change, I think, is important for us to be doing at a population level for all human beings. And supporting patients appropriately with the right treatment, those lifestyle changes kind of come naturally. It just seems easier to do those things.
Can I quickly add that one thing that helped me with how I was thinking about this as well, and the way that we were all kind of raised to say that if you gained weight, it was your fault. Like we all had that message when we were growing up, and still continue to get that message. If people weren't motivated to do something about their weight, there would not be a $3 billion weight loss diet industry. And so the idea that, they just don't want to do lifestyle management, I was like, just look at the numbers. Like there'd be no weight loss industry if that were true.
Dr. Dean, good?
Oh, yes, good. Yes.
All right. So clearly a question probably best directed toward Dr. Dean. What are you experiencing or hearing from clinicians about patient expectations? Are they saying that this is going to be a supplement for a healthier lifestyle, as you've described, or are they looking for it to be let us call it a substitute for a healthy lifestyle?
So starting with, I think the most important thing I do is set that first expectation at that first visit. We're talking about this being a disease process. So I talk to patients that this is probably going to be a lifelong therapy. This is not just doing it for 3 to 6 months until they get their weight down. Like they have a chronic disease that can come back, and we need to be on top of that with our different treatments. So it's really important that we do that at the beginning, and the patients know what they're getting into. This is my problem with a lot of those compounding pharmacies and all the other things happening right now is patients aren't getting that messaging because they see me and they tell me what they're hearing from these compounded pharmacies, and they're not giving that same information. So I think we talked about knowledge is power. It's power for our patients to know what this means and what they're doing for their treatment. So that's essential.
Right.
Absolutely.
I would also add that I really appreciated Dr. Hinn's point about the chronic nature of this, and we wouldn't ask somebody to go off of their hypertension drug. But there is some evidence that there can be deprescribing in certain conditions, like diabetes. Like there are examples of people who no longer need their diabetes medicines. What I worry about right now is it is likely that some people with obesity only need to be on GLP-1s for a shorter period of time. We just don't know how to tell which patients that is. And unfortunately, the industry and the entity with the most money to invest in those types of trials have no motivation to do so. And so I just want to manage our expectations there, because I do think, and have heard from clinical experts, that it is likely some patients will only need a certain period of time, and then things could get reset for them, or maybe they can go off it for a period of time and go back on. But we're kind of in a bit of a bummer situation that we don't have a really good way to fund those really important trials.
Really good point. And that's the adolescent population that I'm really seeing.
And that's so interesting. I'm going to steal that point.
Yeah.
By all means. Sarah, obviously your presentation focused a great deal on cost. It's obviously a huge focus of this discussion. Is there a point at which the cost curve begins to bend, where competition or generic entrants could meaningfully reduce the cost?
And I appreciated that Anna brought this up. I really hope so, but I'm worried. Okay, so hepatitis C is the example most people point to say this is going to work. Guess what? That's the one example we have in the last 11 years of competition bringing down drug costs. In all of the other places like rheumatoid arthritis, oncology, MS, we've seen prices go up with more entrants. So it is kind of on all of us to be like, and this time we're going to get it right, everybody. The competition has to bring down these costs. The part of that I am, the silver lining to that, because that could happen with competition, is that these drugs will go generic soon. So semaglutide is likely to go to generic in 2030 or 2031. We're going to know the negotiated price by the end of November. And so there's going to be now kind of a reset on what the price really represents there. We'll see what kind of bargain CMS is driving with Novo for semaglutide. And so I think that a lot of our concerns about equitable access are probably going to remain until we have genericization of semaglutide. Now, tirzepatide, probably a little bit of a better drug than semaglutide, but at the same time, it's still a really good drug. And so I think that you're likely to see some of this ease with more genericization as opposed to competition. That's my more Debbie Downer view of where we are.
I think that's right. And I do want to say liraglutide, the daily injection,
is generic. Yay!
And you can actually get it on cost plus drugs for $144 a month. That's without insurance coverage. So that from 500 to 144 is a different game for a lot of people and patients. Absolutely.
And I'll add to that. I think one of the reasons we saw the Hep C being so effective is, you would only take one, right? And so they really could leverage this only cover. Yeah, well, only coverage. Yes. And a lot of these other classes of drugs, like a complete exclusion, is just not practical in the market. And so one of the things we brought up is if you cover a single one, you can potentially have this competition in a way that we haven't seen, and maybe. And I think that's where clinical expertise and more knowledge is so important. How important is it to cover multiple of these options versus just one? And the answer is we don't have that information yet. So.
Yeah. All right, let's take a question from the audience if we could. Yes, sir.
Yeah, Chris White from the Institute of Policy and Practice at UNH. Please, probably for Dr. Fenn. I was wondering if obesity, is it considered an acquired condition, a rate-based condition? It's kind of a multi-part question. And
yeah.
If it's hereditary in nature, are there like markers that can be observed? And then the final part is we're talking about treating obesity, but what are we doing for preventing?
Thank you for bringing this up. To start can I start with prevention first? I think prevention is so key, especially with our kids. We're seeing an incidence of kids, like we have a pediatric arm and we see 4-year-olds with fatty liver disease. They're 4, okay? And so prevention is so important, but we're just not there yet, So how I think about it and how I describe it to patients is as humans, 85% of us have the genetics that can cause obesity, okay? But we live in an obesogenic environment from how our food quality is, how we're moving, how we're sleeping. Stress, chronic stress is a big factor here. And also we give medicines, other medicines for medical conditions that can cause weight gain. Like a lot of the mental health medicines or even insulin can cause weight gain. So there's a really complex interplay that happens at that level. And that weight set point can change over time. So for women, for example, puberty, after baby, menopause, perimenopause, those really can change that fat mass set point for certain individuals. So for right now, there's some really cool work going on with Andres Acosta. He's doing some genotype with with computer mapping to see, can we figure out, like we talked about the variability curve, can we figure out which patients with some testing will respond to which drug or which lifestyle or which surgery? And it might be a combination approach for many different things. So we're still in the earlier stages of that, but I think in the next 10 years, I actually see that being the future. Precision medicine, just like we did with precision oncology treatment, is how we're going to approach this disease.
Yeah, great. I
agree.
All right, take another question from the audience. Yes.
Greg Bruce, Oliver Wyman. As an actuary, probably think I'm going in the clinic cost direction. But with morbid obesity having such an impact on like comorbid claim cost, are we seeing GLP-1 treatments actually lowering claim costs? There have been studies in the recent past that have show that they're not really lowering in costs. And I don't know if that's because the time horizon is long enough.
Yes.
Or if that was focused on commercial insurance population.
There's a lot.
You know, you might be paying for this drug, like Emma said, paying for this drug but not reaping the benefit of it. Are we at the point where we can't see actual claim cost reductions through GLP compared with all this?
So for what I've been hearing and talking to payers about, it's really noisy because people with obesity have faced such stigma in the healthcare system. They have delayed care for other things for a really long time. So guess what? People who start to lose weight on GLP-1s start having a lot of hip and knee replacements because they either weren't healthy enough or there was stigma that wouldn't allow them. A bunch of them are getting pregnant because I think it's probably going to end up working for polycystic ovary syndrome, just to go with the clinical over there. And so we see actually claims going up at times. And so I think we need more data to know. Our models have shown there is a point at which over 5 years you can start to see cost savings, but that is only looking at the obesity-related comorbidities. It's not including the fact that they might also be getting care that they've been delaying. That's not a bad thing. Like, I don't want that to be kind of mixed up and being like, then we shouldn't pay for it. No. Let's pay for that because they're not having that stigma anymore with the system.
That's such a good. Do you mind if I just tag on that? So preventative care, patients with obesity don't get it. Right, you see that. They don't get routine like pap smears and mammograms and colorectal screening. Yeah. So we are missing a lot in this population. But when they come and get treated, and guess what? They start believing in the healthcare system again. Yeah. They get their screening. Okay, so it is a way to make our population healthier to do the same screening that we do for patients who don't have obesity.
We need time.
I was going to say, yeah, exactly.
All right. Speaking of time, Dr. Aziz has a question he'd like to ask that came into us via email as part of the public hearing process. And then I'll pitch you one last question and we'll get you out of here.
So, sorry, Iman, so you mentioned something interesting about pharmacologic research and funding. Yeah. Look closely.
Yeah.
I asked my students to do the same. And a lot of the literature is showing the cost benefit or the clinical benefit of these therapies. I think maybe in a way suffer from what's called publication bias, meaning they only publish the stuff that says good stuff. Right? Aside from that, we did get a question from New Futures asking, has the department, the insurance department, which is a state agency which generally inherently doesn't engage in the conduction of research, maybe. I've never read that anywhere, though. But has the department considered a public health analysis? So we do a lot of analyses on the long-term cost benefits of GLP-1 therapies. And we've heard a lot about an existing body of literature on that. But when I saw that question come in, my eyes opened up widely. And I did mention the person who was supposed to be sitting here is Dr. Susan Roberts, who is a very, very talented world-class researcher, and her team right here. And I think that there's a lot of other ancillary benefits, but let me ask you, what does that look like in the state of New Hampshire with all these data assets, access to data assets, maybe types of financial support that might be acquisitional on that end to inform but minimally biased analysis on that?
I'm happy to jump in and I don't know if you're going to like this answer, Jason.
Give it to me.
We need to do it. I think the data are pretty clear about the unbelievable benefits of these drugs for patients with obesity that can lead not only to more health at a very reasonable price, again, leave the budget impact aside, but the long-term value piece, and even some cost savings over a period of time. I don't believe that question is unanswered.
Okay.
That's just my...
Yeah. No, that's good.
I mean, I was just going to add the public health benefits. I fully agree. I think there's a lot of interesting information we could get about a little bit more transparency about the prices that are getting paid and see the data that you have made available, like how many patients are taking it. What do we learn from insurers as kind of average and that payment rate? I think that's very valuable. And we've seen, for instance, in gene therapies, insurers kind of grouping together to kind of try to solve these problems. And when we have these very high cost therapies, I think that's a really important role. because it does impact public health through its impact on costs.
That's a good point, Emma. Let me just comment on that because I wholly agree. I mean, unless we understand the true cost, how can we do an accurate cost benefit analysis?
And like, what are people doing well that is able, they are able to negotiate a lower cost or something like that? What works? And I think we're still figuring that out. And that's where I think your data that you've been able to show has been fantastic.
Thank you for the chance to add up.
Absolutely.
Sometime I can.
I would note that where Jason said we've not been asked or required to do analysis and research, I looked over at Alex. He's like, I've been doing that for 40 years. You're telling me now, just now that I didn't have to do all of that? Thank you, buddy.
Thank you.
All right, last question. I'll throw it open to all of you. If you could give one recommendation to regulators, such as myself and those of us in the room, and policymakers, we're going to send this presentation out to all of them, to ensure that the innovations that we are seeing in this space are sustainable, and you can define sustainable as you'd like. What would that piece of advice be?
Please give our sickest patients a treatment.
There we go.
Mine was very similar. It was, I think, throwing out access for everyone can actually limit access for the people who are most at need, and there is an in-between way to cover some payments.
Negotiate like crazy. Like, just, I think that we can collectively convince the manufacturers that there's a volume play in this for them, and that if the net price continues to come down, they can make it up with more prescriptions, and then we're achieving that population health goal that we all want out of these medicines.
All right, Dr. Finn, Dr. Dean, Sarah, thank you so much for joining us today. Appreciate you very much. All right, not too bad. A little overtime, but not too badly overtime. Just very briefly, housekeeping item. We have a lot of fun, believe it or not, with this event. I think we dive into a lot of important areas, share a lot of important information. But the technical legal requirement for this event is for it to be a public hearing. Just because today's event is going to conclude here in a second, there is still an opportunity for people to offer written comment. That deadline is when? In 2 weeks. Okay, so you've got an additional 2 weeks to submit comments to the department. The email address, you can send it to communications@ins.nh.gov. We will get them to the appropriate individual to answer those questions or to review those comments. So please do take advantage of that if you are not able to join us today. But for now, once again, thank you all so much for coming. We've really enjoyed it. And we'll see you next year, and stay tuned for additional announcements on some events that we've got planned. So be well, everyone.